Good morning, everyone. Hopefully, I'm audible. Let me know if the audio visuals are clear. Then we can proceed. Hopefully, I'm audible. Good morning, everyone. Hopefully, audio visuals are clear. Let me know in the chat box. Bache. Shall we proceed? Great. Now, let's talk about the next part, that is nothing else but appendix beta. If I talk about appendix, we know appendix is usually a blind tubular structure present at the iliocecal junction, right? हमें पता है that the base of the appendix which is there beta, that is going to be fixed, but the apex which is there, which is that apex keeps on varying in position or varying in location. अलग अलग जगह पे होता है apex. That is what is important to remember. Clear? If I talk about what is the most common position of appendix, so please remember the most common position of appendix would be retrocecal. ठीक है? Let me know about the least common one in the chat box. Let me know about the least common one. So we know the most common position of appendix is the retrocecal beta, which is behind the cecum, followed by second most common is going to be pelvic beta. Second most common position is going to be pelvic. So do remember that most common is retrocecal, followed by second most common, which is pelvic. And if they ask you about the least common position, the least common position, if they ask you which is, the answer has to be posterior beta. The answer has to be posterior. Okay, that is behind the ilium. Posterior is considered as the least common position of appendix. That is what is important to be remembered. Clear? Chalo. Very good. Now important is beta if I talk about the next condition, and that is nothing else but acute appendicitis beta. If I talk about acute appendicitis, we know one of the main reasons is going to be obstruction beta, right? So definitely there can be obstruction at the mouth of appendix due to a fecalith, and that fecalith which is there beta, it is actually going to be a leading cause for an obstructive acute appendicitis. Okay, so please remember one of the leading causes is going to be fecalith. Age, we know acute appendicitis occurs commonly beta in 10 to 25 years of age. So 10 to 25 years old patients may definitely appendicitis is much more common beta. In patients of acute appendicitis, bache, do remember that the patient's most constant symptom, if they ask you, the patient's most constant symptom, okay, which is always present, it is nothing else but anorexia or loss of appetite. So anorexia or loss of appetite is a constant symptom in patients of acute appendicitis. And if they ask you which is the most characteristic symptom, so please remember the most characteristic or the most specific symptom in patients of acute appendicitis is going to be a migratory right iliac fossa pain. Matlab, this pain starts from the umbilicus and then it migrates till the right iliac fossa. Let me know which dermatome is responsible for this migration of pain from umbilicus till the right iliac fossa in acute appendicitis. Which dermatome or which nerve segment? The migratory right iliac fossa pain beta is going to be, okay, migratory right iliac fossa pain which is there beta, it is actually going to be the most characteristic or the most specific symptom in patients of acute appendicitis. That is all we know, right? So definitely if they ask you beta, yes, the dermatome that is responsible, we know very good, it is going to be T10. So that T10 dermatome, this was a PYQ, the T10 dermatome is going to be responsible bache, for migration of pain from the umbilicus to the right iliac fossa beta. That is important to remember. Shabash. Now, whenever a patient of acute appendicitis comes to us beta, obviously to assess whether the patient is having a chance of acute appendicitis or not beta, whether appendicitis is likely or unlikely, we tend to assess a scoring system beta, and that is called as Mantel scoring system, right? The Mantras is an abbreviation of the 8 parameters used in the scoring system beta. The name of that scoring system is Alvarado. Okay? So please remember beta, you are going to use the Alvarado or the Mantel scoring system, and with the help of the scoring system we'll see whether the chances of appendicitis are there or not there. So first of all, if I talk about M for migration of pain to the right lower quadrant or migratory pain to the right iliac fossa beta, it is given a score of 1. Next is A for anorexia, given a score of 1. Okay? N for nausea and vomiting, given a score of 1. T for tenderness in the right iliac fossa or the right lower quadrant, given a score of 2 beta. Whereas R for rebound tenderness or rebound pain. Matlab, when I palpate, that time there is no pain. When I leave, that time the patient has pain beta. This rebound pain or rebound tenderness is classically known as with sign. Let me know in the chat box. Rebound tenderness is known as with sign in appendicitis. That is given a score of 1. E for elevated temperature beta, that is fever, given a score of 1. Leukocytosis, that is increased total leukocyte count or increased total WBC count, that is given a score of 2. And S for shift to left beta, shift to left का मतलब होता है more amount of immature WBCs or immature neutrophils is what is called as shift to left. ठीक है, total score has to be 10 beta. Whenever the patient score is going to be less than 5 beta, whenever patient score is less than 5, that means appendicitis is unlikely in this patient beta. There are almost no chances of appendicitis, you can say. When the patient has a score of 5 or 6, that means there is possibility of appendicitis, or you can say equivocal chance. What is equivocal? 50-50% chance beta. So 5 or 6 score hota hai, so we say there is a possibility of appendicitis. 7 or 8 mein appendicitis is likely beta. Yes, okay. Appendicitis is likely when the Alvarado score is 7 or 8, and when that Alvarado score is 9 or 10, that is appendicitis is very likely, or diagnosis of appendicitis is almost certain. Hai hi appendicitis beta. Yeah, so that is what is important. Very good. Rebound tenderness, yes, it is known as Blumberg sign beta. So Blumberg sign is what is rebound tenderness. That is important. Clear? Apart from that, definitely the other signs which are there beta. For example, we know in patients of acute appendicitis, when you palpate the left iliac fossa, the patient experiences pain in the right iliac fossa. The palpation of left iliac fossa causes pain in the right iliac fossa is classically called as the Rovsing sign beta. Okay. Next, as I've told you, the rebound tenderness which is there, that rebound tenderness is basically called as the Blumberg sign, which it is classically known as the Blumberg sign. Apart from that, definitely there are two more signs. One important is whenever the appendicitis is retrocecal in position beta, then what happens? Whenever you extend the right leg or whenever you extend the right hip of the patient beta, patient has a lot of pain, and that is classically called as psoas sign. Yeah, right now psoas sign is positive whenever the location of acute whenever the location of appendix is retrocecal, whereas whenever the location of the appendix is pelvic beta, okay, whenever the location of appendix is pelvic, then definitely there is obturator sign. What is obturator sign? Whenever you try to internally rotate the right hip, whenever you internally rotate the right hip, that causes pain basically beta. That is what is important to be remembered. Clear about that is known as the obturator sign. Hopefully clear. Now if they ask you in patients of acute appendicitis, what will be the investigation of choice? I hope all of you are quite aware beta. Investigation of choice, the same rule follows bache. That is for an adult, the investigation of choice has to be a CECT abdomen or a contrast enhanced CT scan. Whereas for children, definitely it is an ultrasound abdomen or a USG abdo. Clear? So the same rule follows here also for the abdominal problem beta. That is important to be remembered. Now, if they ask you what is the treatment, so we know beta, acute appendicitis is always a surgical emergency, and therefore we have to go for a surgery, and that surgery is nothing else but appendectomy or appendicectomy, whatever you call it is fine. Okay? So here we have to go for a surgery beta, that is appendectomy or appendicectomy. When I talk about the appendectomy beta, it can be either an open appendectomy or a laparoscopic appendectomy, right? Either it could be an open or a laparoscopic appendectomy beta. There are two possibilities. If it is a case of an open appendectomy beta, I hope all of you are quite aware definitely we are going to have, or we are going to make a oblique incision beta. Okay, we are going to make an oblique incision basically at the McBurney's point. This is called as the McBurney's incision. This green incision which is there beta, it is the McBurney's incision. It is an oblique incision made in the right iliac fossa. Important, there are two types of McBurney's incision beta. The muscle splitting variety is called as gridiron. The muscle splitting, okay, muscle splitting variety is gridiron beta, and the muscle cutting variety which is there, it is Rutherford Morrison incision. The muscle cutting variety will be Rutherford Morrison. Apart from that, two to three fingers below the umbilicus, 2 to 3 fingers below the umbilicus in the right iliac fossa, if you make a horizontal or a transverse incision, that horizontal or transverse incision is known as a Lanz incision beta. That horizontal or transverse incision is known as the Lanz incision. Hopefully clear to all of you now. So these are the important things to be remembered. If they ask you, definitely beta, we are having a pregnant female and she presents to us with cases of acute appendicitis. Let me know in the chat box, when a pregnant female comes to you with complaints of acute appendicitis, or treatment is Ochsner-Scheren regime, conservative management, emergency appendectomy, elective appendectomy. Let me know in the chat box. What will be your treatment definitely in a pregnant female with acute appendicitis? WBC shift to left means more amount of immature WBCs. Very good. I hope all of you are quite aware now. So whenever a pregnant female comes to us with acute appendicitis beta, treatment is always an emergency appendectomy. Reason is, we all know bache, that pregnancy is an immunocompromised state. If you're not going to operate the female beta in the emergency, obviously that appendix is going to perforate, and if in case the appendix perforates beta, not only the fetus, the mother's life is also in a danger beta. That's the reason we always go for an emergency appendectomy beta. That is what is important. Clear? So do remember this. Next important, if I talk about, is nothing else but, for example, a case of appendicitis comes to you beta, and when you palpate the right iliac fossa, you are able to palpate appendicular lump beta. This is very important because 3 lines will be of acute appendicitis. One line mein they will say that lump is palpable. Why it happens? Reason is, during appendicitis, the appendix is inflamed and it is sticky. As the appendix will be sticky, the omentum comes and wraps around the appendix beta. It gets adhered around the appendix. It gets stuck around the appendix. चिपक जाता है उससे. Clear? And due to that, you are able to palpate the appendicular lump. Whenever there is an appendicular lump, we know it is due to adhesions. And we know in cases of adhesions, बच्चे we don't operate. ठीक है? Therefore, in cases of appendicular lump, we always manage the patient conservatively with the help of Ochsner-Scheren regime beta. Yes, Ochsner-Scheren regime is a conservative management. Do remember that. Okay? Ochsner-Scheren regime is going to be a conservative management. Same. We have to keep our patient NPO, give IV fluids, give antibiotics, okay, and give analgesics. So NPO, IV fluids, IV antibiotics, and analgesics beta. That is what is called as the Ochsner-Scheren regime, and that is the treatment for an appendicular lump. That is important to remember. In any trimester. Emergency का मतलब क्या होता है बेटा? So that is important. If they ask you definitely about recovery. Now, when you are giving Ochsner-Scheren regime, or when you definitely do a conservative management in the patient beta, obviously what you will do, you will monitor the patient. And if you're monitoring the patient, and if the patient recovers beta, and if the patient recovers, in those conditions, what we should go for? In that condition, I should discharge the patient beta, and then I should call the patient after a span or after a gap of 6 weeks bache. And 6 weeks later, I should take up my patient for a surgery, and this time that surgery will be called as an interval appendectomy. Right? Whenever you do a surgery, basically after a gap of 4 to 6 weeks beta, that is called as a interval surgery. So it is the interval appendectomy that we will do after 6 weeks. Reason is, we want all the adhesions which are there beta to get resolved once, and once adhesions are resolved definitely bache, then we will go for a surgery. If there is no recovery beta, you are monitoring the patient of appendicular lump after conservative management, but still there is no recovery. Matlab, what you were palpating beta, it was not an appendicular lump, it was an appendicular abscess. And if it is an appendicular abscess beta, okay, it will not get treated only by conservative management. Better go for an extraperitoneal drainage beta. In this condition, or in this regard, you have to go for extraperitoneal drainage bache. then definitely the patient's condition is going to improve. Clear about? Sure. So these are the important points that you need to remember about appendix. Now, if they ask you, beta, let me know which is the most common congenital anomaly of pancreas, beta. So, if they ask you definitely pancreas के बारे में, the most common congenital anomaly in pancreas. Please remember it is not annular pancreas. ठीक है? We know pancreas is going to develop from two buds, beta, ventral bud and a dorsal bud. But when this ventral and dorsal pancreatic buds will not fuse with each other, beta, that condition is basically called as what? That condition is basically called as pancreas divisum. And whenever there is a pancreas divisum, beta, the pancreatic secretions are not able to drain. And whenever pancreatic secretions cannot drain properly, bache, obviously the patient is going to have high risk of acute pancreatitis, beta. That is what is important to be remembered. Yes, very good. Now here we are having a question which states a male patient presents to the ER or presents to the emergency room, beta, with a sudden onset severe epigastric pain, beta. The patient is having a sudden onset severe epigastric pain, and that epigastric pain which is there, beta, it radiates on lying supine, or it worsens on lying supine, beta, whereas it is relieved on bending forwards. So this is very classical presentation, beta. We know chest pain which radiates to the interscapular area or exactly center of the back, beta. It is a case of aortic dissection. We see severe epigastric pain, beta, radiating on lying supine or worsening on lying supine, whereas relieved on bending forward, is a classical picture of acute pancreatitis, beta. Barabar, we know here there will be nausea, vomiting, fever like features. Now they are asking you what is the next best step in the patient, beta. So if I talk about likely diagnosis, we know there is a classical presentation of acute pancreatitis over here. Let me know, beta, what is the most common cause of acute pancreatitis in children. I'm not asking you overall. Most common cause of acute pancreatitis overall is gallstones, but in children, let me know. So this is a classical diagnosis of acute pancreatitis, beta. हमें पता है most common cause of acute pancreatitis overall is gallstones followed by alcohol, beta. So gallstones followed by alcohol is the leading cause of acute pancreatitis that we all know. But मुझे बताओ बच्चों में, in children definitely what is the leading cause of acute pancreatitis? Very good. So we know, beta, in children the most common cause of acute pancreatitis is nothing else but trauma. Blunt abdominal trauma or a blunt epigastric trauma, beta, like bicycle handle injuries. Clear? So blunt abdominal trauma or a blunt epigastric trauma, it is the leading cause of acute pancreatitis in children, beta. That is important to be remembered. Clear? Important is if they ask you in patients of acute pancreatitis, definitely, beta, what is the radiological investigation of choice? We know pancreas is definitely, beta, a retroperitoneal organ, and मैंने एक बात बताई है तुम्हें, for all the retroperitoneal structures the best radiological investigation is always a CECT abdo, beta. That is what is important to be remembered, right? The best radiological investigation is always a CECT abdomen. That is important. So here in cases of acute pancreatitis also, the best radiological investigation will be a CECT abdo, and on that CECT abdomen, this time this kind of picture can be seen. This is the edematous pancreas that you are able to see, and this is nothing else but the blood collected. So it is not only a case of pancreatitis, but this is a case of, or this is a picture of a acute hemorrhagic pancreatitis. Okay, and we know whenever there is a acute hemorrhagic pancreatitis, this kind of bleeding can be seen, beta. That is what is important to be remembered. Clear? And acute hemorrhagic pancreatitis mein whenever there is bleeding, beta, okay, obviously there will be bleeding in the peritoneal cavity called as hemoperitoneum, and due to hemoperitoneum these two signs will be seen, beta. One is there is bruising around the umbilicus called as a Cullen's sign. One is bruising around the umbilicus called as the Cullen's sign, beta, and the second one is bruising in the flanks, beta, and that bruising in the flanks is classically called as the Gray Turner sign. The bruising in the flanks is classically known as the Gray Turner sign, beta. That is what is important to be remembered. Clear about? So Cullen sign and Gray Turner sign are the two classical signs, which are usually seen in a patient of acute hemorrhagic pancreatitis, beta. Let me know in the chat box these two signs of hemoperitoneum. They are also seen in which obstetric emergency. Therefore, that obstetric emergency is a close differential for acute hemorrhagic pancreatitis. Anybody, let me know in the chat box which obstetric emergency. Please remember that the CCT that we do in patients of acute pancreatitis beta, yes, very good. It is ruptured ectopic pregnancy beta, जहाँ पे definitely you are able to see the signs of hemoperitoneum as well. Very good. And we know CCT abdomen in patients of acute pancreatitis is usually done after 72 hours. So it is not used for diagnosis. Yes, diagnosis of acute pancreatitis is not made with CCT abdomen. It is just used basically to assess the severity in case of pancreatitis. मुझे बताओ then what is the best investigation? What here what will be the next best step? What is going to be the best investigation to confirm the diagnosis of acute pancreatitis? For confirmation of diagnosis, the best investigation is going to be, let me know in the chat box. We know that there are criteria or scores also beta. The criteria or the score which is there definitely based on signs and symptoms or based on clinical manifestations. If you tell the severity of pancreatitis, that is known as the Ranson score or the Ranson's criteria. So Ranson's score or Ranson's criteria mein, so based on the signs, symptoms or the clinical manifestations of the patient beta, we decide the severity of acute pancreatitis. Whereas the second is known as the Balthazar grading. Okay, the second is known as the Balthazar grading beta. Please remember this Balthazar grading is basically a CT severity index. Matlab based on the CT findings beta, you are going to tell the severity of acute pancreatitis. At least remember these two scores beta. Very good. Yes, we know that the best investigation overall which is there, it is serum lipase followed by serum amylase beta. Now we know why serum amylase is not the best one. Reason is beta serum amylase is not very specific for pancreas. इसीलिए the best is always serum lipase बच्चे. The best is always going to be serum lipase followed by serum amylase. Clear बात? So these are the important points that you have to remember. These are the important points that you need to remember. And we know management in cases of acute pancreatitis is not surgical beta. Okay, so please remember definitely surgical acute pancreatitis which is there, it is just managed conservatively beta. We just go for a conservative management and pure IV fluids, IV antibiotics and analgesics. So the same conservative management has to be done. And please tell me beta, a lot of people are getting confused over here. I've seen that acute pancreatitis जब होता है, definitely you will start the nutrition, you will start parenteral nutrition or enteral nutrition. So initially we will give parenteral nutrition beta, IV fluid जैसा मैंने बोला, but we will try to start on enteral nutrition as early as possible. I've told you one thing. So try to start enteral nutrition as early as possible beta. That is what is always recommended. Please remember that. ठीक है? Enteral nutrition should be started as early as possible. Do remember that. Next important is here. Patients of acute pancreatitis may have beta paralytic areas, and as they have paralytic areas, therefore when you see a X-ray abdomen of these patients beta, on that X-ray abdomen definitely you are able to see this classical picture called as the colon cutoff sign. So this is classically called as the colon cutoff sign which is, so please remember colon cutoff sign which is there. It is usually seen in the X-ray abdomen of in patients of acute pancreatitis beta. Okay, so that is basically due to paralytic areas in patients of acute pancreatitis. Hopefully clear to all of you now. So do remember that. Next important if I talk about is nothing else but a complication of acute or chronic pancreatitis. When I talk about a complication of acute or chronic pancreatitis, that is known as pseudocyst. क्या होता है इसमें? Here inside the granulation tissue beta there is collection of fluid, and whenever there is collection of fluid inside the granulation tissue, that condition is known as pseudocyst. Now please remember pseudocyst is a very common condition beta and can be seen in multiple cases, but majority of the time pseudocyst is very small in size, it is asymptomatic and it resolves spontaneously. अपने आप ठीक हो जाता है बेटा, अपने आप चला जाता है within 4 weeks. ठीक है? But sometimes definitely the pseudocyst will be big in size, it will be symptomatic and it may not resolve beta even after 6 weeks. In those conditions we may have to go for treatment beta. Pseudocyst mein the patient starts complaining of what? In pseudocyst beta, whenever the patient has pseudocyst, the patient starts complaining of epigastric fullness, epigastric pain, postprandial fullness, nausea and vomiting, right? So these kind of symptoms which are there basically beta, they can happen when the patient is having a large pseudocyst. And we know the most common site bache for the pseudocyst to develop, the most common site for the pseudocyst to develop definitely is the lesser omentum, lesser sac of the omentum. So lesser sac which is there beta of the omentum is considered as the commonest site for the pseudocyst to develop. That is important to remember. Clear about? Now please remember sentinel loop sign is different. Sentinel loop sign is going to be basically a single loop with a lot of air inside it definitely. That is a sentinel loop sign. Okay? So that is what is important. Sentinel loop means a gas filled air loop definitely, which is much more prominent. Clear? That is sentinel loop. दोनों में बहुत डिफरेंस है, दैट इज व्हाट इज इंपॉर्टेंट. Please remember that if they ask you, definitely. Okay, in cases of this one, in case of pseudocyst beta, we know we have to go for CCT abdomen again, as you are able to see in the picture, because again it is a retroperitoneal fluid collection. So CCT abdomen pe you are able to see such kind of fluid collection, that is a pseudocyst. Treatment, we know beta, as it is a fluid collection or as it is a cyst, we have to go for drainage, but we have to follow the rule of 6. What is that rule of 6? If the size of the cyst is more than 6 centimeter beta, if the size of cyst is more than 6 centimeter, or if definitely beta, if the cyst is more than 6 weeks old, so more than 6 centimeter size, more than 6 weeks old, or wall thickness more than 6 mm. In these conditions beta, we go for a treatment, and the treatment is nothing else but drainage. Internal drainage can be done. Now internal drainage is what? Internal drainage is a cystogastrostomy, when you open up the cyst into the stomach for drainage, or you can open it up in the intestine, that is called a cystoenterostomy beta. So either you can go for a cystogastrostomy or a cystoenterostomy, which is for the purpose of drainage. But we know whenever the whenever definitely beta, it is infected, whenever the cyst is going to be infected beta, in cases of infection we don't tend to, in cases of infection definitely beta, we don't tend to drain it internally, otherwise the infection will spread. इसीलिए in case of infection we drain it externally beta, and we know external drainage is always done with the help of a pigtail catheter. So under the ultrasound or CT guidance beta, you can definitely drain the cyst beta with the help of pigtail catheter. Pigtail catheter drainage can be done. Hopefully that's clear to all of you now. So these are the important points. Yeah. Now let's talk about liver. If I talk about liver, basically beta, please remember that there are two infections that you have to remember in liver beta. That is pyogenic liver abscess and amoebic liver abscess beta. Both of them are important. If I talk about pyogenic liver abscess, we know pyogenic liver abscess is the infection which usually happens due to bacteria. Amoebic liver abscess, by the name it is evident, the cause is amoeba. So pyogenic liver abscess, it is polymicrobial beta, matlab multiple bacteria together are actually responsible for causing the pyogenic liver abscess. But still, if they insist that what is the most common cause, the single most common cause of pyogenic liver abscess beta is going to be nothing else but E. coli or Escherichia coli beta. Why? Because here the E. coli or the Escherichia coli goes from intestine into the bile ducts. It causes cholangitis, right? That is infection of the bile ducts, and then it spreads upwards into the liver beta. So from intestine to the bile ducts, and from bile ducts to the liver beta, that is how it spreads. Important beta, if I talk about pyogenic liver abscess in Asians, is not caused by E. coli. हमें पता है बेटा, we Indians definitely don't get afraid of these kind of bacteria like E. coli. We need a stronger bacteria, and that is definitely Klebsiella बच्चे. ठीक है, तो please remember definitely we need Klebsiella for causing an infection. Clear? So worldwide most common cause is E. coli, but in Asia the most common cause is Klebsiella बच्चे. That is important. Clear? Amoebic liver abscess, by the name it is evident, the cause is going to be Entamoeba histolytica. So Entamoeba histolytica is the causative agent. Here what happens? Patient has a contaminated food and water. Due to contaminated food and water intake, patient develops intestinal amoebiasis, and from the intestine beta, then the amoeba penetrates, and then ultimately it reaches the liver. Now important, how does the amoeba penetrate? The amoeba penetrates beta by causing these kind of ulcers. Let me know in the chat box what are these type of ulcers called as basically. Let me know in the chat box definitely. I hope all of you are quite aware that intestinal amoebiasis mein, when the amoeba penetrates and these kind of ulcers are formed, they are classically called as what? All of you are quite aware. They are flask-shaped ulcers. But this has been a previous year image-based question. Do remember that. These are the flask-shaped ulcers that you have to remember. Okay? The flask-shaped ulcers are going to be seen in the intestinal lumen of the patient beta. That is important. Yeah. Very good. Next important, if they ask you now, most common site. Yeah, right now pyogenic liver abscess can happen equally in the right as well as the left lobe of the liver, but amoebic liver abscess, which is there beta, it is more commonly seen in the right lobe of the liver. Amoebic liver abscess is more commonly seen in the right lobe of the liver, especially which quadrant? Especially the posterior-superior quadrant beta. Especially the posterior-superior quadrant. Okay, in this side definitely, which the amoebic liver abscess is going to be much more common. Clear? If they ask you about the clinical features, if they ask you definitely about the clinical features, so please remember that we know common clinical features will be there, as both of them are infections, but in both the conditions there will be fever. Just pyogenic liver abscess mein there will be high grade fever, amoebic mein low grade fever will be there. Second, in both the condition, as the liver is getting damaged, both the patients are going to come to us with icterus or jaundice beta. Third important, both the conditions may the patient will have pain in the right hypochondrium. So right hypochondrium or right upper quadrant pain will be seen in both the condition. And lastly, in both the condition, as there is pus collection in the liver, due to pus collection in the liver beta, both the patients will come to us with complaints of hepatomegaly. The only difference, as I've told you, is pyogenic liver abscess may the symptoms are going to be much more severe beta, but symptoms are not very severe in a case of amoebic liver abscess. We know patients of pyogenic liver abscess appears toxic. Amoebic liver abscess they don't appear toxic. Next important, investigation of choice. याद रखना, radiological investigation of choice, same rule follows. If the patient is an adult, we go for a CCT abdo. If the patient is a child, we go for an ultrasound abdo beta. So CCT abdomen or ultrasound abdomen has to be done definitely. But अगर वो पूछेंगे which is the best investigation overall or which is the investigation of choice to confirm the diagnosis, because CCT or ultrasound cannot confirm our diagnosis beta. Clear? So therefore pyogenic liver abscess, as it is a bacterial infection, we know beta, here the investigation of choice has to be nothing else but pus or blood culture beta. बराबर? तो plus pus culture or blood culture which is there, it is the best investigation or the investigation of choice to confirm the diagnosis in patients of pyogenic liver abscess. Whereas we know amoebas cannot culture, and if amoeba cannot culture, here the investigation of choice is an ELISA or immunoblot. So serology can be done beta, that is an ELISA or an immunoblot. That can be the investigation of choice, which in a case of nothing else but amoebic liver abscess beta. That is important. Hopefully clear to all of you now. If they ask you what is going to be the treatment, we know pyogenic liver abscess is a bacterial infection, so treatment has to be IV antibiotics beta. So we have to give IV broad spectrum antibiotics like third or fourth generation cephalosporins, and then we have to go for an early aspiration or drainage beta. Then we tend to go for an early aspiration or drainage again with the same pigtail catheter beta. Clear about? So IV antibiotics and drainage for pyogenic liver abscess has to be the treatment. For amoebic liver abscess, we know the drug of choice for amoebiasis is nothing else but your metronidazole. Barabar? So here you will start the patient on metronidazole beta. Now important is if the patient responds well to metronidazole beta, if the patient recovers, then in those conditions I will continue the metronidazole therapy. Along with that, I will add diloxanide beta. Right? We will continue metronidazole if the patient responds, and along with that add diloxanide. Reason, metronidazole can kill the amoeba inside the liver, but to kill the amoeba in the intestine, we need diloxanide furoate. If the patient doesn't respond, matlab even after giving metronidazole, the patient's condition doesn't improve beta, in those conditions, better go for an ultrasound guided aspiration or drainage beta, and that ultrasound guided aspiration or drainage again done with the help of the same machine, nothing else but the pigtail catheter. So this one that you are able to see beta, the TD Poochwala catheter, this is basically your pigtail catheter. Okay, so this is the pigtail catheter beta used for fluid or the pus drainage basically from the abdomen. Now we know whenever we aspirate or whenever we drain the amoebic liver abscess beta, we are going to get a very classical kind of pus, and that classical pus that you tend to get basically beta in a case of an amoebic liver abscess is classically known as the anchovy sauce pus or a chocolate pus. So anchovy sauce pus or chocolate pus which is there beta, that you tend to get basically if it is a case of an amoebic liver abscess beta. That is what is important to be remembered. Hopefully clear to all of you now. Sure. These are the points that you have to keep in mind beta. Okay, about the liver abscess. Another infection of the liver which is there beta, that is nothing else but hydatid cyst. Another infection of the liver, if I talk about, it is nothing else but hydatid cyst, which when I talk about hydatid cyst, it is an infection caused by a dog tapeworm. And what is that dog tapeworm? We know that dog tapeworm which causes this infection is nothing else but Echinococcus granulosus beta. Okay, that dog tapeworm which is actually known to cause hydatid cyst, it is Echinococcus granulosus. Do remember, most common site affected is definitely the liver beta, but okay, most common site affected is the liver, but apart from liver, lungs are also affected or other organs are also affected beta. That is important to be remembered. Now we know definitely that liver followed by lungs are the commonest organs affected. Now if there is a single hydatid cyst, we know the causative agent is going to be Echinococcus granulosus beta. We know the causative agent is Echinococcus granulosus. Let me know definitely beta if there will be multiple hydatid cysts. I have told you malignant hydatid we call it as. If there are multiple hydatid cysts or malignant hydatid, what is the causative agent? Let me know in the chat box. Multiple hydatid cyst or malignant hydatid, what is the causative agent? We know here also the patient will come to us with the same features, like there will be hepatomegaly, jaundice, right hypochondrium, discomfort or pain, and fever beta. These are the common features even in a patient of hydatidosis or hydatid cyst beta. Important is again here also radiological investigation of choice की अगर मैं बात करूँ बेटा, it has to be definitely the CECT abdomen or the ultrasound beta. Radiological investigation of choice is CECT abdo or ultrasound depending on the age of the patient. Adults में CECT, बच्चों में ultrasound. And when you do a CECT, you are able to see a very classical appearance beta. Let me know what is this classical appearance when the endocyst is going to float inside the cavity or inside the cyst beta. Let me know that also in the chat box. What is this classical appearance or sign called as? Very good. So yaad rakhna, definitely this was a PYQ in your examination. Whenever the patient is having multiple hydatid cyst, definitely, or malignant hydatid beta, the causative agent is nothing else but Echinococcus multilocularis. By the name it is evident, and a lot of people did a mistake last time when this question came. Okay, so the causative agent is an Echinococcus multilocularis beta. Do remember that. That is what is important to be remembered. Clear? So don't mark granulosus for multiple cysts. Okay. Yes, so please remember definitely beta, here you are able to see the classical picture, and that is nothing else but floating water lily sign beta. This is classically known as the floating water lily sign. That is important to be remembered. Also called as serpent sign. So either I can call it as the floating water lily sign beta, or we can call it as the serpent sign. That is a classical sign beta on the CCT abdomen in a patient of hydatid cyst. याद रखना बेटा, we know there is a Gherbe's classification which was followed earlier, and now there is a WHO classification. We know according to the Gherbe's classification beta, floating water lily sign is going to be type 2, and according to the WHO classification it is type 3 beta. Do remember that? ठीक है, so that is what is important to remember. If they ask you definitely बच्चे, ठीक है, तो Gherbe's याद रखना, पहले वाला classification था, the name was asked in the FMGE examination. And in NEET PG, so they have also asked which type of Gherbe's is floating water lily sign. Answer is type 2. Next important is beta, best investigation which will be done to confirm the diagnosis beta. We know that dog tapeworm which is there, it cannot culture. If it cannot culture, the best investigation is serology again, that is ELISA or immunoblot beta. So ELISA or immunoblot which is there, it is considered as the best investigation to confirm a diagnosis of hydatid cyst beta. That is important. If they ask you treatment, हमें पता है the first line treatment. Now the drug of choice for tapeworm infection or the drug of choice for echinococcus infection beta, it is nothing else but albendazole. Barabar? So here we have to give a drug that is nothing else but albendazole, which is, that is important to be remembered. Apart from albendazole, definitely beta, we have to give which therapy? Pair therapy beta. Along with albendazole, we have to give pair therapy definitely. And when I talk about pair therapy beta, what is pair therapy? Definitely pair therapy is percutaneous aspiration, injection of scolicidal agents and reaspiration. Matlab, here we have to first of all drain all the fluid collected inside that cyst. After that, once the cyst is empty, then you have to inject scolicidal agents inside it beta. And then after waiting for some time, then you have to reaspirate the scolicidal agents back. That is pair therapy, percutaneous aspiration, injection of scolicidal agents and reaspiration beta. Clear? If in case the pair therapy is contraindicated, we know now there are conditions we have discussed where pair therapy is contraindicated, like if it is an extra hepatic cyst outside the liver, or if it is a dead or a calcified cyst. Okay, in these kind of conditions, pair therapy cannot be done. In those conditions, which if there is a single cyst, in those conditions, if there is a single cyst, then we can go for a surgery, and that surgery is nothing else but a cystopericystectomy beta. In that condition, we go for a surgery called as a cystopericystectomy. Iska matlab, you have to surgically remove the cyst along with the outermost covering known as pericyst. So cystopericystectomy has to be done. Whereas if they ask you beta multiple cyst, definitely. So please remember multiple cyst which is there, definitely beta. In this condition, I cannot go for even a cystopericystectomy for each and every cyst. Okay. So when I cannot go for separate surgery for all of the cysts, then better is remove the part of the liver beta which contains all this cysts. That is called as liver resection. So remove the part of the liver which contains all these cysts beta. That is nothing else but liver resection. Hopefully that's clear to all of you now. So do remember beta, this is what is the case of hydatid cyst definitely beta, or hydatidosis. Clear? Next important if they ask you definitely is most common malignancy in liver beta. If they ask you, these are some one liners. The most common malignancy in liver, which we know it is nothing else but metastasis. Wherever, so metastasis basically is considered as the most common malignancy in liver beta. Whereas if they ask you which is the most common primary malignancy, the most common primary malignancy in liver is going to be hepatocellular carcinoma. Right? Most common primary malignancy in liver is hepatocellular carcinoma. Let me know beta that with which adulteration disease or with which toxin the hepatocellular carcinoma is associated. PSM का question. Let me know in the chat box that which toxin or which adulteration disorder is commonly associated with HCC or hepatocellular carcinoma. Let me know in the chat box. याद रखना hepatocellular carcinoma is also called as hepatoma. It is commonly associated with hepatitis B, hepatitis C, as well as thorotrust exposure. Thorotrust is a dye beta that is important to be remembered. Clear? Very good. And the toxin and the adulteration disorder that is associated basically with HCC or hepatocellular carcinoma. Very good, all of you. It has to be a case of aflatoxicosis, or the toxin responsible is aflatoxin beta. Yes, groundnut industry. Next important, if I talk about bache, is most common primary liver tumor in children. If they ask you which is the most common primary liver tumor or primary liver malignancy in children, answer will be an hepatoblastoma. Answer is going to be hepatoblastoma is the most common liver tumor in children beta. That is important to be remembered. And last, definitely, if they ask you beta, is going to be most common benign liver tumor in which is the most common benign liver tumor. So overall, if they ask you which is the most common benign liver tumor beta, the most common benign liver tumor is going to be hemangioma. The most common benign liver tumor which is there beta, it is going to be hemangioma. That is important to be remembered. These are the points that you need to keep in mind beta. Clear? Followed by that, definitely another one which is there beta. Okay, so hemangioma is the commonest one. Followed by that, the next one is going to be FNH, that is focal nodular hyperplasia beta. So yeah, hemangioma is the commonest one that we have. Followed by that, we have FNH, that is focal nodular hyperplasia. Anybody can tell me why all the benign liver tumors are common in females? Why are all the benign liver tumors common in females beta? All the benign liver tumors like hemangioma, focal nodular hyperplasia, or even hepatic adenoma more commonly seen in females itself. What is the reason behind that? All the benign liver tumors are more commonly seen in females. Anybody? The reason behind that is nothing else but beta OCP intake. हमें पता है all the benign liver tumors are commonly associated with the OCP or the oral contraceptive pill intake beta. That is the reason why they are more commonly seen in females. Yes. Next, if I talk about definitely which is nothing else but gallbladder now. If I talk about gallbladder bachche, that is nothing else but gallstones now. So first of all, gallstones, when I talk about, we know gallstones is nothing else but cholelithiasis beta. याद रखना, don't get confused between cholelithiasis and choledocholithiasis. Cholelithiasis means gallstones and choledocholithiasis means stones inside the common bile duct. Doco means duct. Clear? So important is if I talk about the gallstones or the cholelithiasis, definitely in a patient beta, we know there are three major types of gallstones beta. The first one are going to be the mixed type of gallstones. Second one are the pigmented gallstones, and the third ones are the cholesterol gallstones. So we know that the most common type of gallstones overall are going to be the mixed gallstone. The most common type of gallstones overall will be the mixed gallstones beta. Second, the most common type of gallstones in Asian population. The most common type of gallstone in the Asian population is going to be the pigmented gallstone. You can just remember Asians are more pigmented. So most common type of gallstone in Asians are the pigmented gallstone. And if there is a fat female in her, fat fertile female in her 40s beta. So this fat female fertile who is in her 40s, definitely she will have more chances of cholesterol gallstones beta. Due to hypercholesterolemia, they will have more chance of cholesterol gallstone. हमें पता है majority patients of gallstones or cholelithiasis which are there beta, they are completely asymptomatic. Yes, majority patients of gallstones or cholelithiasis are completely asymptomatic beta. It is just an incidental diagnosis. But sometimes definitely patient may have a symptom. And what is that symptom? Anybody? Let me know. Symptom in patient of gallstones beta will be a right hypochondrium pain or a right upper abdominal pain beta. But that worsens after what? Anybody let me know in the chat box. That worsens after intake of what? Please tell me beta. Right hypochondrium pain can be there in patients of gallstones beta, which worsens after. Right hypochondrium pain which worsens after. So we know right hypochondrium pain which is there beta, and that worsens after fatty meals. That is a very classical presentation of gallstones or cholelithiasis beta. Right hypochondrium pain which worsens after fatty meals basically beta. Yes, that is the reason why that is the classical presentation in a patient of gallstone. We know 90% gallstones are radiolucent beta, And when I say 90% gallstones are going to be radiolucent, bache, that means they will appear black on X-ray or a CT scan. Therefore, neither a X-ray nor a CT scan will be good enough to diagnose a gallstone, beta. The investigation of choice has to be a ultrasound abdomen. Now, important is when I do a ultrasound abdomen in a case of gallstone, beta, please tell me basically what is the important feature which will differentiate a case of gallstone from a gallbladder polyp. This has been a PYQ in your examination. So please remember, beta, if you want to differentiate a case of gallstone from a gallbladder polyp, beta, on an ultrasound abdomen, definitely. What is the most important feature to differentiate? So if they ask you what is the most important feature to differentiate, I hope all of you are quite aware, beta. It is going to be this feature, right? What is this feature? Shabash. Yes, it is going to be nothing else but the posterior acoustic shadow. In case posterior acoustic shadow is present, beta, that is a case of stone, right? Whenever posterior acoustic shadow will be present, bache, that is a classical case of stone. But whenever this posterior acoustic shadow will be absent, that is going to be a case of nothing else but gallbladder polyp, beta. ठीक है, तो posterior acoustic shadow, if it is present, it is a gallstone. If posterior acoustic shadow is going to be absent, that is a gallbladder polyp. That is what is important. Treatment अगर वो पूछेंगे बच्चे, do remember that in case of gallstone, definitely the treatment which is there, it is nothing else but cholecystectomy. We know if there are multiple gallstones, if there is a stone more than 2 centimeter, so if there are multiple gallstone more than 1.5 to 2 centimeter का largest stone, or the patient definitely having porcelain gallbladder, gallbladder polyp with stones, in all these conditions it's always better to go for a removal, that is cholecystectomy. Either we can go for a open cholecystectomy or a laparoscopic cholecystectomy, okay, either a open or a laparoscopic cholecystectomy can be done. Let me know in the chat box for open cholecystectomy which incision is taken in the right hypochondrium. For open cholecystectomy, which incision you tend to take, bitche, in the right hypochondrium. Let me know in the chat box, beta. Now this was a previous year image based question, beta, from August 2020, where you are able to see a calcified gallbladder. And this calcified gallbladder which is there, beta, it is classically called as a porcelain gallbladder. And why important is porcelain gallbladder, which we know that porcelain gallbladder is going to be important. Reason is it is a pre-malignant condition. Now, when I say it is a pre-malignant condition, obviously, beta, it can develop further into a gallbladder cancer. And as it can develop further into gallbladder cancer, therefore, a cholecystectomy or gallbladder removal will always be indicated, beta. Okay, a cholecystectomy or gallbladder removal will always be indicated. So, yaad rakhna, porcelain gallbladder is the condition that is shown over here, and it is pre-malignant condition, beta. That is what you have to remember properly. Okay, so these are the things that you need to remember. Open cholecystectomy के लिए please remember that we take a Kocher's incision. I've told you that Kocher's incision in the right hypochondrium. Kocher's incision in the right hypochondrium is taken for open cholecystectomy. And next, let me know in the chat box that strawberry gallbladder is a feature of which condition? Strawberry gallbladder, which is there, definitely it is seen in which condition? Let me know in the chat box. Strawberry gallbladder which is there, it is seen when definitely there will be deposition of cholesterol flakes, beta, on the gallbladder wall. When the cholesterol deposits on the gallbladder wall, that leads to a classical appearance like a strawberry, beta. And that strawberry gallbladder which is there, definitely it is usually seen in a condition that is nothing else but that condition is classically known as the cholesterolosis, beta. That condition is classically called as cholesterolosis. So cholesterolosis of gallbladder, definitely, beta, not in cancer. Cholesterolosis is the condition, definitely is the condition jahan pe the patient is going to have a strawberry gallbladder. Cholesterolosis is not a pre-malignant condition. It cannot increase the risk of cancer. That is important. That's the reason why cholecystectomy is not required for cholesterolosis of gallbladder. Clear? Next important is this classical triad that you are able to see. First, you are able to see basically brackish appearance inside the gallbladder. Why? Obviously, because there will be air or gas inside the gallbladder. As there will be air or gas inside the gallbladder, beta, that is a case of pneumopedia. That is a classical case of pneumopedia. Next, here you are able to see multiple air fluid levels, beta. And these multiple air fluid levels which are there, beta, they are suggestive of small bowel obstruction or intestinal obstruction, beta. That is important. Okay? And third, you are able to see a shadow inside the terminal ileum or inside the right iliac fossa. And the shadow in the terminal ileum or the right iliac fossa is a classical gallstone, beta. Okay, so please tell me, beta, this is called as which triad and seen in which condition? Okay, this is which triad? Pneumobilia, small bowel obstruction and gallstone. Okay, this is which triad and seen in which condition. We know beta, यहाँ पे patient comes to us with complaints of small bowel obstruction. Beta, patient comes to us with complaints of small bowel obstruction. Okay, why it has happened? Because there was a fistula between the gallbladder and the duodenum. As there was formation of a fistula between the gallbladder and the duodenum, beta, stone of the gallbladder came into the duodenum and it has went all the way up to the terminal ileum, causing a blockage or obstruction, beta. That is causing small bowel obstruction. Second, the gas or the air from the duodenum has also gone inside the gallbladder, and therefore there is a pneumobilia which is seen. Very good. This is classically called as the regular stride, beta, and I hope all of you are quite aware that regular stride which is there, it is usually seen in a condition that is nothing else but which condition में दिखता है? Regular stride. Very good. It is usually seen in a condition that is gallstone ileus, beta. So whenever gallstone is causing an intestinal or bowel obstruction, that is gallstone ileus. याद रखना regular stride which is there, it is usually seen in a condition known as the gallstone ileus, beta. That is important to remember. So regular stride is seen over here. So regular stride is pneumobilia, air fluid levels of small bowel obstruction definitely, and gallstone. Pneumobilia is nothing else but air inside the gallbladder. Okay, that is important to be remembered. We know treatment has to be initially conservative jaoge because the patient comes to you with bowel obstruction. Later on, after the diagnosis, you go for exploratory laparotomy, beta, and therefore you can go for stone removal. Clear? Here there is a question which states, a patient presents to you, beta, with complaints of sudden onset right upper quadrant pain. The patient is having a sudden onset right upper quadrant pain or a right hypochondrium pain, along with other features like fever, nausea, and vomiting. The sign given below is elicited. What is the sign? Here you are palpating the right iliac fossa of the patient. And when you palpate the right iliac fossa of the patient, definitely, beta, then what is going to happen? The patient will have so severe pain that the patient is going to catch his breath, beta. On palpation of the right iliac fossa, patient catches the breath due to pain. This is classically called as the Murphy's sign, beta. हमें पता है that Murphy's sign, if it is positive, beta, it is a classical case of nothing else but what is the likely diagnosis? I hope all of you are quite aware. Whenever Murphy's sign is positive, along with right hypochondrium pain, fever, nausea, and vomiting, has to be a classical diagnosis of acute cholecystitis, beta, right? So the classical diagnosis of the patient is nothing else but acute cholecystitis, which that is important to be remembered. Yes, so it is a classical case of acute cholecystitis, beta. So याद रखना है बहुत. And we know, beta, acute cholecystitis can be of two types. मतलब either it is a calculous cholecystitis or a acalculous cholecystitis. What do I mean by that? Calculous cholecystitis is the one which happens basically due to gallstones, beta. Acalculous cholecystitis is the one which happens even without gallstones, beta. That is what is important to remember. Okay, the calculous and acalculous cholecystitis are the ones that can happen. Investigation of choice. We know, beta, for acute cholecystitis, the investigation of choice is nothing else but an ultrasound abdo. Even in adults. Okay? So adults, maybe for acute cholecystitis, the diagnosis can be easily made just with an ultrasound abdomen, beta. That is important to be remembered. Clear? If they ask you what is going to be the treatment, beta. So now do remember, if they ask you what is going to be the treatment in the patient, treatment in cases of acute cholecystitis is nothing else but initially a conservative management, beta. Okay? Initially a conservative management, NPO, IV fluids, IV antibiotics, and analgesics, beta. Conservative management. Why? Okay, now after that, whether we have to go for an emergency cholecystectomy or not, whether we should go for an emergency cholecystectomy or not, beta, that depends on the time of presentation. Matlab, if the patient is presented to you early, beta, now the risk of adhesions will be less. ठीक है, अगर patient जल्दी आया तुम्हारे पास, तो the chance of adhesions is going to be less, beta. You can go for a immediate removal or a immediate cholecystectomy. But if the patient has presented to you late, beta, अगर 2-3 दिन बाद आया, so obviously we know, beta, the patient will have more chances of adhesions, and whenever there will be adhesions, beta, you should not go for immediate surgery. Otherwise, you will injure the bowel, beta. That is the reason. Okay? So conservative management plus minus cholecystectomy, beta, will be the treatment definitely that we go for acute cholecystitis, beta. That is important. Yes, gold standard would be a HIDA scan. Now, next important, if I talk about bache, is the question over here. What you are able to see here, we are having a neonate, beta, who has complaints of progressive jaundice. We are having a neonate who complains of progressive jaundice, beta, at birth, basically. With which kind of urine? With a dark urine and pale stools, beta. I hope all of you are quite aware, beta. Whenever the child comes to you with a jaundice, basically, and that jaundice is going to be, beta, associated with darker urine and a pale stool, then please let me know, is it a case of pre-hepatic jaundice, hepatic jaundice, or post-hepatic jaundice? ठीक है. Post hepatic is also called as obstructive jaundice. Let me know in the chat box whenever the jaundice is going to have dark urine and pale stools associated with it, beta, is it a pre-hepatic, hepatic, or post-hepatic jaundice? Here they are saying that the LFT, the liver function test, also shows, beta, there is raised levels of ALP. What is ALP? Alkaline phosphatase. So even the alkaline phosphatase levels which are there, beta, those are elevated. This is also a feature of pre-hepatic, hepatic, or post-hepatic jaundice. So I hope all of you are quite aware. याद रखना ये बात that whenever a patient is going to have a jaundice along with dark urine and pale stools, it is a classical case of post hepatic jaundice. That is an obstructive jaundice. That is some problem inside the bile duct, beta. As there will be obstruction in the bile duct, the bile is not able to drain. That's the reason the stool doesn't get its color, and therefore it is a case of pale stools. Second important, definitely, beta, the urine is going to be much darker in color. नहीं भाई, it is post hepatic. Pre hepatic में dark urine and pale stools are never seen. That is what is important to be remembered. Definitely याद रखना है बात. तो please remember this. ठीक है. तो jaundice which is definitely there with dark urine, pale stools and a raised ALP. हमें पता है, we have discussed in biochemistry also, ALP, that is alkaline phosphatase, is very much specific for a biliary tree or bile duct pathologies, beta. बराबर. ALT and AST are liver enzymes, but ALP which is there, it is definitely suggestive of some bile duct pathologies, beta. That is important to remember. Clear? अब मुझे बताओ, what is the problem in the child's bile duct that he has come to you with jaundice immediately at birth, basically, beta, and that too with a raised ALP levels. ठीक है. Obstructive jaundice in a child, basically, which is present at birth, basically, beta. Obstructive jaundice which is present at birth, definitely, which is progressive in nature. What is the problem in the bile duct? The likely diagnosis of the case is going to be biliary atresia. What is biliary atresia? We know that when definitely the bile ducts are not properly formed in the child, that is biliary atresia. So here definitely there is inflammatory fibrosis of the bile ducts, and as there will be inflammatory fibrosis of the bile ducts, that's the reason why the bile ducts are not going to be formed. Okay, clear about? So that's the reason why the bile is not able to drain, causing a post hepatic or an obstructive jaundice, beta. We know there are three types of biliary atresia, beta. The first one, here you can see, beta, type 1 में the CBD or the common bile duct is not formed. So type 1 is CBD atresia. Type 2A, तो हमें पता है बेटा, type 2A which is there, definitely यहाँ पे CHD, that is common hepatic duct, is not formed. Type 2A is CHD atresia, basically. Next is type 2B. Type 2B में there is atresia of the common bile duct, there is atresia of the common hepatic duct, along with that there is atresia of the cystic duct. So when there is atresia of all the three external ducts, beta, that is CBD, CHD and the cystic duct, then we call it as a type 2B. And last is type 3, beta. Type 3 में you can see even the internal ducts are not formed, beta. So when there is atresia of all the ducts, basically, when there is atresia of the whole biliary tree, that is type 3. याद रखना, type 1 means CBD atresia, type 2A means CHD atresia, type 2B means common bile duct, common hepatic duct and cystic duct atresia, and type 3 is going to be all ducts atresia. Clear? Investigation of choice. We know, beta, investigation of choice in a patient of biliary atresia is usually HIDA scan. So hepatic immunodiacetic acid scan, which is there, that is HIDA scan, is considered as the investigation of choice for biliary atresia. But intrahepatic atresia में HIDA scan is not useful. So intrahepatic atresia में definitely, beta, the best investigation is always a liver biopsy. So intrahepatic atresia के लिए the best investigation which is there, it is always a liver biopsy. That is important. Clear? So do remember that. Next important, if I talk about this type 1, beta. Now what is the treatment, basically? So if I talk about type 1 biliary atresia, हमें पता है type 1 में what was the problem? The common bile duct or the CBD was not formed. When the common bile duct or the CBD is not formed, बच्चे, what we will do? We will just pull up our vella friend. Who is our vella friend? That is jejunum, beta. We will just pull up our jejunum, bच्चे, and connect the jejunum directly to the common hepatic duct, and that surgery will be called as the Ru-NY hepaticojejunostomy. Let me know what you do basically for the treatment of type 2 and type 3 biliary atresia. Let me know in the chat box 2 or 3 के लिए क्या करते हो. Type 1 के लिए तो we have discussed, it is Ru-NY hepaticojejunostomy. Now type 2 and 3 जो होता है definitely here, so even the other ducts are also not formed. So what we do here, we directly connect the intestine or the bowel, beta, to the porta hepatis. Porta hepatis is a small portion below the liver. That surgery is known as portoenterostomy, also called as which surgery or which operation? So type 2 and type 3 biliary atresia are treated by portoenterostomy, which is also called as which surgery or which operation? Very good. So we know beta, it is classically called as the Kasai surgery or the Kasai operation. So Kasai surgery or Kasai operation, which is there, it is usually done for the type 2 and the type 3 biliary atresia beta. This is what is important to be remembered. Clear about? Chalo. So these are the points. Next important, if they ask you what is this investigation, let me know in the chat box. What is this investigation basically? Whether it is a MRCP or a ERCP beta. The investigation that has been shown over here, is it a MRCP or a ERCP? This investigation is an MRCP or a ERCP, anybody? Yes, it is a ERCP beta. Why it is a ERCP? Definitely endoscopic retrograde cholangiopancreatography. Reason here, the endoscope is visible. Along with the bile ducts beta, you are able to see the endoscope is also visible. So it has to be nothing else but a ERCP, endoscopic retrograde cholangiopancreatography. That was a previous year question basically from radiology to identify the investigation. Next important is this investigation. Again a PYQ. Here you are able to see beta a picture of the bile duct. Okay, that is a cholangiogram, and in that you are also able to see a T tube. So this is basically called as a T tube cholangiogram. This picture which is there beta was a T tube cholangiogram that you are able to see. Hopefully clear to all of you now. So do remember this. So this is a T tube cholangiogram which is seen. Next important, if I talk about nothing else but the choledochal cyst beta. Now what is cyst? Basically it is a dilatation over here. Okay, so choledochal cyst means when there is dilatation of the common bile duct beta, and whenever there is a dilatation of common bile duct, that is called as choledochal cyst definitely, and the patient will come to us with the complaint of a choledochal triad. When I talk about a choledochal triad, the patient is going to have a very classical feature: pain, lump and jaundice beta. The patient will have a classical choledochal triad called as pain, lump and jaundice. Okay, important is, let me know in the chat box beta that pain, fever and jaundice is called as which triad and seen in which condition. Pain, fever and jaundice is which triad and seen in which condition beta? Let me know in the chat box. So here the lump which is there beta, it is palpable because of definitely the cystic dilatation of the bile ducts basically. We know that the classification that we use for choledochal cyst is nothing else but the Todani's classification beta. Okay, so the classification that we use for the choledochal cyst is called as the Todani's classification. That is important to be remembered. And according to Todani's classification, definitely beta, it is going to be Morrison's pouch is nothing else but the hepatorenal pouch. मैंने फास्ट में explain किया था उसको. Morrison's pouch is the hepatorenal pouch definitely. It is the pouch definitely between the liver and the right kidney. That is important to be remembered. If I talk about definitely, if I talk about the Todani's classification over here, please remember that type 1 which is there. Okay, so type 1 which is there beta, इसमें क्या दिखता है? There is a single cyst basically in the common bile duct. When there is a solitary extrahepatic cyst or a single extrahepatic cyst in the CBD, that is what is called as the type 1. टाइप 2 जो होता है बेसिकली, टाइप 2 में देयर इज आउट पाउचिंग फ्रॉम द कॉमन बाइल डक्ट. तो प्लीज रिमेंबर द आउट पाउचिंग बेसिकली फ्रॉम द कॉमन बाइल डक्ट इज नोन एज एक्स्ट्रा हेपेटिक डाइवर्टिकुलम. सो टाइप 2 is an extra hepatic diverticulum that is going to be seen. Type 3 में you are able to see beta, type 3 में here the opening of the CBD is very narrow. As the opening of the CBD is narrow, therefore the intraduodenal portion of the CBD gets dilated, and when the intraduodenal portion of CBD is dilated, that is called as choledococele. Clear है बात? Next important is going to be type 4A. We know type 4A is nothing else but multiple cysts beta which are seen inside the liver as well as outside the liver. Matlab type 4A is multiple extrahepatic as well as intrahepatic cyst beta. That is what is important. Type 4B, हमें पता है type 4B में there are multiple cysts but all of them are outside the liver only. That is type 4B will be multiple extrahepatic cysts beta that will be found. And type 5 which is there beta, type 5 is nothing else but again multiple cysts are seen but all of these cysts are usually within the liver. That's the reason type 5 is nothing else but multiple intrahepatic cysts beta. That is important. और हमें पता है that type 5 or the multiple intrahepatic cyst is also called as Caroli's disease beta. That has been important, that has been asked. They asked you basically that Caroli's disease is which type of choledochal cyst. All of us are quite aware it is type 5 choledochal cyst. Second question they asked basically, this picture was given in the examination beta and they asked you it is which type of choledochal cyst. So we know definitely this is a choledococele, that is nothing else but a type 3 choledochal cyst beta. That is important to be remembered. Clear about? Next important, if they ask you investigation of choice, हमें पता है investigation of choice for any bile duct problem is going to be MRCP beta. So MRCP is going to be the investigation of choice, that is magnetic resonance cholangiopancreatography. Now, why MRCP will be the investigation of choice and not ERCP? Reason: MRCP is a non-invasive investigation, beta. I don't need to inject or insert something. It is just a T2 weighted MRI basically of the bile ducts. Okay. If MRCP fails to make a diagnosis, beta, then the gold standard investigation which is there, that is ERCP. Reason: ERCP is invasive, and second important, ERCP is not only diagnostic but also therapeutic. It can also help us in treatment, beta. That is important to be remembered. Clear? So these are the important things that you have to remember. हमें पता है बेटा, for the type 1 choledochal cyst, here what we have to do? Here we have to remove the common bile duct, beta, and we have to connect the jejunum directly to the common hepatic duct. And we know when we connect the jejunum directly to the common hepatic duct, that is called as Roux-en-Y hepaticojejunostomy, bitch. That will be a Roux-en-Y hepaticojejunostomy. Next, type 2 method, it's very easy. Just remove this diverticulum, bitch. Just cut out this diverticulum and repair the common bile duct. When you just cut the diverticulum and repair the CBD, that is the treatment for type 2. Type 3 mein we know why there is a choledococele, because definitely beta the intraduodenal portion of CBD is dilated. Why it is dilated? Reason: the CBD opening is very narrow. So just go with ERCP and just widen the opening by doing a sphincterotomy. Just make cuts over the sphincters, beta. So type 3 mein the treatment is ERCP with sphincterotomy, beta. Type 4A and type 5 what is the common feature? Type 4A and type 5 definitely, but in both the conditions there are multiple intrahepatic cysts, and whenever there are intrahepatic cysts, beta, the best treatment is always a liver transplantation. So type 4A and type 5 दोनों के लिए the best treatment is always liver transplantation, beta. That is important. And lastly type 4B. Type 4B में तो definitely we know the whole external bile ducts which are there, those are affected. So here definitely I remove the whole biliary tree outside the liver and I connect the intestine directly to the porta hepatis, that is portoenterostomy, also called as Kasai procedure. So type 4B is treated by Kasai surgery, beta. Clear? Now let's talk about urology, beta. Here you are able to see the first picture. This is a CCT abdomen on which what is seen. Here I am able to see a pair of ectopic kidneys, beta. Okay, why I'm saying ectopic? Because both of them are not in their original position, beta. So here both the kidneys are ectopic in nature, and if you see the lower pole which is there, beta, it is fusing with each other. As both the kidneys are ectopic and the lower pole is fusing in the midline, beta, it is a classical appearance of which shape? Horseshoe shape, which shape. So this is a classical case of a horseshoe kidney. Now important is, please tell me, beta, what is the most common site of fusion, or what is the most common level of fusion in horseshoe kidney? The lower poles of the kidneys fuse, but exactly at which level basically, let me know in the chat box. So horseshoe kidney which is there, definitely, beta, they usually fuse at which level basically, let me know in the chat box, beta. What is the most common site of fusion for a horseshoe kidney, which that is important. If I talk about horseshoe kidneys, beta, we know in this condition, beta, if you do a IVP, okay, here if you do a IVP, definitely, that is intravenous pyelogram or intravenous pyelography, you are able to get a very classical appearance, beta, called as the flower vase appearance, also called as the hand joining or the hand shaking sign, right? We call it as the flower vase appearance, also known as the hand joining or the hand shaking sign, beta. That is what is important to remember. Okay, the flower vase appearance, hand joining sign or hand shaking sign, it is one and the same thing. हमें पता है patient may complain of pain, hematuria, or due to urine retention. Patient may also have stones and infections, beta. Treatment is always and always conservative, beta. We never go for a surgical management for horseshoe kidney. Reason is, yeah, Ragna, if you try to cut the kidneys, beta, they will actually, that will actually cause more damage to the kidneys. So conservative management is the only approach, beta. Symptomatic management, no surgery is done in case of horseshoe kidney. Yeah, yes. So please remember, beta, L3, L4 is the site of fusion, beta. The junction of L3, L4, which is there, definitely, beta, it is the site of fusion basically for the lower poles of the kidneys, beta. Clear? That is important. Next important, if I talk about as a picture, beta, jahan pe you are able to see that both the kidneys are enlarged, beta, and the patient comes to you with complaints of lumbar pain. When you see both the kidneys are enlarged and there is lumbar pain, beta, you do a CCT, and on that CCT abdomen you are able to see this classical picture, beta. What is seen in this classical picture? I am able to see multiple fluid filled cysts, beta. I am able to see multiple fluid filled cysts in both the kidneys, beta. So this is nothing else but a classical case of PCKD, beta. Barabar? It is a classical case of PCKD, that is polycystic kidney disease. We already have discussed in the class, beta, that PCKD or polycystic kidney disease, which is there, definitely. Okay, PCKD or polycystic kidney disease, which is there, beta. It is actually of two types. Sorry, either it is autosomal recessive or it is autosomal dominant, beta. Barabar? It is either autosomal recessive or autosomal dominant. We know the autosomal recessive variety is the infantile variety, and with all the patients die in that variety. With autosomal recessive infantile variety, it is incompatible with life. So the patient that comes to you usually is the autosomal dominant variety beta. The patient that definitely comes to you which is the autosomal dominant variety. And when I talk about the autosomal dominant variety, definitely beta, please remember what is the gene mutation. हमें पता है बेटा that the gene mutation which is seen in the autosomal dominant variety which is there, it is nothing else definitely beta but the PKD1 or the PKD2 gene mutation, right? The gene mutation which is seen over here, it is nothing else but beta the PKD1 or PKD2 gene mutation. These are the gene mutation which are associated with the autosomal dominant variety of polycystic kidney disease, which is called as a congenital or the adult variety, right? This is known as the congenital or the adult variety beta. That is important to be remembered. If they ask you in patients of PCKD or in patients of ADPKD beta, in this condition, if they ask you that the symptoms are going to appear after what age, तो याद रखना symptoms in PCKD usually appear after 30 years of age बेटा, ठीक है? That's the reason why it is also called as an adult variety, ठीक है? Symptoms appear after 30 years of age, and the most important symptom is hypertension. Most important symptom is hypertension, along with there will be pain and hematuria. So hypertension is the main symptom beta. Apart from that, yes, there will be pain and hematuria also in the patient. Now in this condition, again CECT abdomen has to be the investigation of choice. Why? Because it is the retroperitoneal structure. I've already told you retroperitoneum में the best investigation is always the CCT. And जब अगर IVP करोगे, let me know in the chat box that IVP in patients of polycystic kidney disease will give you which kind of appearance beta. IVP or intravenous pyelogram gives you which kind of appearance. हमें पता है बेटा ट्रीटमेंट के लिए वी कैन ईदर गिव एंटी हाइपरटेंसिव्स लाइक एस इनहिबिटर्स, बराबर? तो एस इनहिबिटर्स लाइक एंटी हाइपरटेंसिव्स लाइक कैप्टोप्रिल, लिसिनोप्रिल, दीज कैन बी द ड्रग्स व्हिच कैन बी गिवन बेटा. Apart from these drugs, I can also go for a Rovsing surgery. Rovsing is nothing else but beta deroofing of the cyst. As I've told you that this surgery is not very commonly done. The only reason being beta, even if you do deroofing of the cyst, again the new cyst is going to develop beta. ठीक है, तो Rovsing surgery is not a very good choice. The best treatment is always renal transplant. The best treatment is always a renal transplant beta. That is important to be remembered. याद रखना. If they ask you IVP which is there in patients of PCKD beta, very good. The IVP or the intravenous pyelogram gives you a very classical appearance known as spider-like appearance beta. It definitely gives you a classical spider-like appearance. That is what is important to be remembered. ठीक है, so याद रखना ये बात. Important is beta if they ask you in cases of renal transplantation beta which kidney is preferred. So we know beta renal transplantation में it is always the left kidney which is preferred. Reason, the left renal vein is longer. As the left renal vein is longer beta, therefore we prefer left kidney. Please tell me beta, we place the new kidney definitely in the right iliac fossa, बराबर? We place the new kidney in the right iliac fossa due to the risk of rejection. मुझे बताओ definitely beta that maximum rejection rate is for which organ? PYQ and FMG exam, maximum rejection rate is basically for which organ beta? Let me know in the chat box. Maximum rejection rate is for transplantation of which organ? Let me know in the chat box basically. Maximum rejection rate definitely not kidney. Yes, it is. We know better that maximum rejection rate is basically for lungs. Definitely 80% rejection rate is there for lung transplantation and 50% rejection rate for kidney transplantation beta. Kidney transplantation, yes, it is one of the most common, not the it is one of the most common basically beta. So it is lungs followed by kidney definitely, that you have to remember. Clear about that? Is important to be remembered beta. Yes, some books definitely say it is kidney, but please remember better answer is lungs basically because Bailey clearly says lungs. Okay, so that is important to be remembered. Next important, if I talk about, yaad rakhna, here you are able to see a picture better, that is IVP or intravenous pyelogram. On that you can see that the pelvis of the patient which is there better, it is drooping down, and as the pelvis is drooping down, it classically looks like basically a drooping lily sign beta. So here I am able to see a pyelogram definitely which is giving us a classical drooping lily sign. Clear about? So drooping lily sign which is there definitely, it is seen on the IVP or intravenous pyelogram. That is important to be remembered. If they ask you about the drooping lily sign beta, please remember it is a classical feature of which condition? However, the drooping lily sign, if it is seen definitely, drooping lily sign if it is seen beta, it is a classical feature of nothing else but duplex renal pelvis and ureter beta. whenever there is duplication of the renal pelvis and ureter, whenever there is duplication of the renal pelvis and the ureters beta, that is instead of one pelvis there are two pelvis in one kidney beta. So duplication of renal pelvis or duplex renal pelvis and ureter is the classic it is the condition definitely jahan pe the duplex drooping lily sign will be classically seen beta. Hopefully that's clear to all of you now. So do remember, this is the important point that you have to keep in mind beta. ठीक है, चलो, no issues with this anybody, याद रखना है बात. Next important if they ask you, ठीक है, done with this. Okay, hopefully that's clear to all of you now. So here if I talk about beta in cases of duplex renal pelvis and ureter, याद रखना duplex renal pelvis and ureter में one thing you have to keep in mind, and that is nothing else but beta, here you have to go for ureteric reimplantation if there is an ectopic ureter. If there is ectopic ureter, then you go for a ureteric reimplantation beta. You create a new opening for the ureter in the urinary bladder. Next is a picture beta where there is a small child or a neonate who has been brought to you beta, and that child is having complaints of urine retention. When you did a IVP or intravenous pyelography, definitely beta, in this you are able to see this kind of picture. क्या दिख रहा है? Here you are able to see beta, the contrast is not able to flow properly from the ureters basically. Second, there is retention of the urine inside the pelvis beta. There is retention of urine inside the pelvis and the cholecystitis. Therefore, the renal pelvis and the renal cholecystitis appears to be dilated बच्चे. Okay, the renal pelvis and the cholecystitis appear to be dilated definitely over here. That is important to be remembered. Clear है बात? तो याद रखना. And this dilated renal pelvis and cholecystitis we know is called as hydronephrosis. So due to urine retention, the patient is having hydronephrosis on the IVP beta. But if you properly observe that there's hydronephrosis in a small child over here, and that too due to some obstruction at the pelvic-ureteric junction. So it is a classical picture of nothing else but PUJ obstruction beta. It is a pelvic-ureteric junction obstruction. I hope all of you remember that most common cause of congenital hydronephrosis basically. Most common congenital cause of hydronephrosis is nothing else but PUJ obstruction or pelvic-ureteric junction obstruction itself beta. Important is, let me know beta, that pelvic-ureteric junction obstruction अगर होगा, pelvic-ureteric junction obstruction अगर होगा बेटा, what is the investigation of choice? Investigation of choice for hydronephrosis or investigation of choice for pelvic-ureteric junction obstruction. Here there will be a severe urine retention. Due to that the kidneys will get damaged beta. ठीक है, so please tell me what is the investigation of choice in this condition. Which nuclear scan has to be done for PUJ obstruction or for hydronephrosis? Anybody? Anybody? We know that investigation of choice is a MAT3 scan beta. We know that there are two types of scan in the kidneys basically beta. Very good. One is going to be the DMSA scan बच्चे. DMSA scan is nothing else but an anatomical scan for kidneys beta, and second is a DTPA or the MAC3 scan beta. Okay, so definitely second is a DTPA or a MAC3 scan definitely, which are functional scans which will tell us about the kidney function or the GFR of the patient beta. Clear? So that is important. Now if they ask you, definitely beta, in patients of PUJ obstruction, we have discussed beta what is the treatment. याद रखना, treatment in PUJ obstruction is nothing else but a surgery known as Anderson-Heinz pyeloplasty beta. तो हमें पता है that Anderson-Heinz pyeloplasty which is there, it is the surgery that we perform बच्चे in a patient. Okay, Anderson-Heinz pyeloplasty definitely is the surgery that we perform in a patient of PUJ obstruction. So Anderson-Heinz pyeloplasty can be done. No issues with this anybody? Hopefully that's clear to all of you now. Anderson-Heinz pyeloplasty surgery का नाम याद रखना बेटा please. Next, सरकारी question बोलो. In your examination, this is a सरकारी question बेटा. Here you can see the ureteric openings are very narrow. As the ureteric openings are narrow, they are not able to drain properly, causing dilatation of these ureteric openings, and dilatation of this dilatation of the intravesical ureter which is there beta. It is giving you a very classical sign on the IVU. On the intravenous urography, you are able to see a very classical appearance. This is a case of which condition? So please remember beta, it is, yes, it is a classical picture of nothing else but a ureterocele beta. This is a classical picture of a ureterocele we know, and we know whenever there is a ureterocele definitely बच्चे याद रखना ureterocele में you are going to see a very classical cobra head or a adder head appearance beta. That is what is important to be remembered. Barabar, you have to definitely see this appearance, that is a classical cobra head or a adder head appearance बच्चे. cobra head or a adder head appearance, definitely if you are able to see on IVP, that is a classical presentation of nothing else but beta ureterocele. Yes, it is sarkari beta. Majority cases are unilateral beta. Just by looking at the image, don't say always ki it is going to be more commonly bilateral. No. Yes, there are bilateral cases. Exam में more commonly they have given bilateral, but majority cases are unilateral beta, almost 90%. Clear है बात? That is important to be remembered beta. And treatment, हमें पता there are two treatment options over here. First, one, I can make incision at the ureteric opening, but the problem is when you make a cut or when you make an incision on the ureteric opening beta, the ureteric opening can definitely widen up too much, and if it widens up too much beta, a complication can happen. And what is that? Backflow of urine from the bladder into the ureter. And whenever there is backflow of urine from the bladder to the ureter, that is called as vesico-ureteric reflux beta. So the vesico-ureteric reflux can definitely happen. Clear है बात? इसीलिए the better treatment is ureteric reimplantation beta. That is, create a new opening itself beta for the ureter on the urinary bladder. तो नया opening बना दो definitely for these ureters on the urinary bladder beta. That is important to remember. Clear? Next important is this picture. Here you are able to see IVP or intravenous pyrography beta. And if I talk about definitely intravenous pyrography बच्चे, here you are able to see a classical appearance. What is this classical appearance beta? Here the ureter is taking a turn and going behind the inferior vena cava. As the right ureter takes a turn and goes behind the inferior vena cava beta, on IVP we are able to see a very classical appearance, and that is nothing else but the fish hook ureter, also called as the reverse J-shaped ureter. We are able to see a fish hook ureter beta or a reverse J-shaped ureter, definitely. That is important to be remembered. And we know whenever there will be a fish hook ureter or a reverse J-shaped ureter, definitely that is a classical case of what? That is a classical case of definitely nothing else but retrocaval ureter beta. That is a classical case of nothing else but a retrocaval ureter. ठीक है, so that is what is important to be remembered. तो retrocaval ureter पे there will be a fish hook or a reverse J-shaped appearance of the ureter beta. So here there are two options. Either I can cut that part of the ureter which has gone behind the IVC and I can join the remaining parts, that is ureteric anastomosis beta. Okay, ureteric anastomosis is one option. Second option is I can just lateralize the ureter, and lateralization of the ureter can be done with the help of a DJ stent or a double J stent beta. Clear? So DJ stent or the double J stent looks like this, which will be inserted in the ureter either for lateralization or more commonly for ureteric strictures. So whenever there are ureteric strictures beta, in those conditions a DJ stent is going to be used. Clear? Chalo, next important, if I talk about definitely, which is the case now. Here we are able to see a case of urinary stones. We know urinary stones are nothing else but any stones which are usually formed inside the urinary tract beta. Whether it is definitely the renal stones or the bladder stones, doesn't matter. So renal or bladder stones which are there, definitely beta, these are going to be a urinary stones. That is important to be remembered. If I talk about urinary stones over here beta, do remember that most common cause of urinary stones अगर वो पूछेंगे तो answer is idiopathic hypercalciuria, right? So we know what we don't know exactly what is the cause, but majority cases में if there is hypercalciuria beta, ठीक है, majority cases में whenever there is a hypercalciuria, more calcium excreted out in urine, in those conditions beta there is a high chance of urinary stones to be formed. So idiopathic hypercalciuria we have discussed beta is the most common cause of urinary stones. That is important. Now when they ask you which are going to be the most common type of urinary stones, the most common type of stones formed in the urinary tract बच्चे are always the calcium oxalate stones. हमें पता है that calcium oxalate stones which are there beta, they are usually formed by calcium oxalate stones are usually formed beta by two types of crystals. Either definitely it will be the monohydrate crystals or the dihydrate crystals. बराबर, the monohydrate and the dihydrate crystals which are there, definitely they are going to form the calcium oxalate stones. Important is, let me know beta one thing, that calcium oxalate stones are usually seen in which condition? Biochemistry से बताओ. Okay, which condition में definitely calcium oxalate stones are seen? Let me know in the chat box. Calcium oxalate stones will be seen in which condition? That is important. If I talk about clinical feature, we know beta, whenever the patient will have any infection or any stone in the urinary tract beta, any infection or any stone in the urinary tract, the commonest symptom is always increased urinary frequency beta. The commonest symptom is always an increased urinary frequency. Patient has to go for urination again and again beta. That is important. We know other features, the most important feature, that is pain beta. another most important feature is pain. तो याद रखना, if I talk about beta first, lumbar pain है अगर किसी patient में, if a person is only having a lumbar pain which is not radiating, so if a patient is having a fixed lumbar pain beta which is not radiating anywhere, that means the patient is actually having a kidney stone beta or a renal stone. So fixed lumbar pain not radiating anywhere is a feature of renal stone or a kidney stone. Next, if the patient is having a lumbar pain beta but that is radiating to which sides? Radiating to multiple sides beta. ठीक है, it can radiate to the perineum, scrotum, inner thigh, iliac fossa, anywhere. ठीक है, तो lumbar pain radiating to the scrotum, perineum, inner thigh, iliac fossa at these sides beta. That means the stone is inside the ureter बच्चे. That means it is a ureteric stone or ureteric calculi beta. तो ureter में जब भी stone होता है, the patient is going to have a lumbar pain which is radiating to different sides. Third important, whenever the patient is having a suprapubic pain, we know whenever the patient has a suprapubic pain beta, that means the stone is usually inside the urinary bladder beta. So whenever the stone is whenever the stone is in the bladder beta, patient is going to complain of a suprapubic pain bache. And the last one, whenever the patient will have a suprapubic pain which is radiating beta, whenever the patient complains of a suprapubic pain, definitely radiating beta. ठीक है, तो suprapubic pain radiating to the tip of penis. In that condition, either the stone is at the level of the urinary bladder neck beta or then the urethra. Then the stone is at the level of the urinary bladder neck or the urethra. That is important to remember. Hopefully that's clear to all of you now. Chalo. Very good. Hyperoxaluria is the condition beta. Hyperoxaluria is the condition जहाँ पे the patient will have calcium oxalate stones beta. That is important to remember. Clear? Yeah. Now if I talk about beta, we know whenever a patient of stones comes to us beta, obviously if we are suspecting stone beta, we should send a urine microscopic examination, and when we send a urine microscopic examination, we'll be able to see the shape of crystals, and depending on the shape of crystals beta, we can definitely analyze that which kind of stone will be present in the patient's urinary tract beta. First, if the shape of crystal is going to be dumbbell shape bache, so we know these are going to be the monohydrid crystals. Whenever the shape of crystal is dumbbell shape, these are going to be the monohydrid crystals, and whenever it is envelope shape beta, it is going to be dihydrid crystals. Barabar. So monohydrid will be dumbbell shaped and dihydrid is going to be envelope shaped crystals, and both of these are nothing as but type of calcium oxalate stones itself. Barabar. Both of these are nothing as but the type of the most common type of stones called as the calcium oxalate stones beta. Next important, if I talk about bache, is hexagonal shaped crystals. We know that hexagonal shaped crystals or the benzene ring shaped crystals. So hexagonal or benzene ring shaped crystals is seen in cystine stones definitely. And we know beta cystine stones are the hardest renal stones out of all. So cystine are going to be the hardest renal stones out of all, and they are seen in a condition called as cystinuria. Let me know in the chat box beta which kind of urine is seen in patients of cystinuria. Which kind of urine is usually seen in a patient suffering from cystinuria beta. Let me know in the chat box. Next important, हमें पता है बेटा that coffin lid shaped crystal which is there. Coffin lid shaped crystal is a feature of triple phosphate stone, also called as struvite stone. हमें पता है triple phosphate stone which is there beta, it is made up of calcium, magnesium and ammonium phosphate, right? Triple phosphate stone is made up of calcium, magnesium and ammonium phosphate beta. These are also known as struvite stones, and it is very commonly associated with a protease infection. We know na triple phosphate stones are usually formed in a alkaline urine beta, and alkaline urine is definitely due to a protease urinary tract infection, which that is important to be remembered. Clear? Last is irregular shaped crystals. Irregular or universal shaped crystals, if they ask you beta, तो याद रखना irregular or universal shaped crystals, if they ask you, then definitely it is a case of nothing else but the uric acid stones. So you know uric acid stones or the urate stones which are there, okay, they are going to have irregular or universal shaped crystals. They are usually seen in a patient of gout beta. They are usually seen in patients of gout. And second, wherever there is hyperuricemia. Apart from that, you have to remember that this uric acid stones which are there beta, they are radiolucent stones. So radiolucent ka matlab the stones which will appear black on an X-ray or a CT scan. Now we know beta that majority of the renal stones are unlike gallstones beta. Majority of the renal stones are radio opaque. They will appear white on X-ray or CT. Therefore, X-ray and CT can be used for diagnosis beta. But radiolucent stones like the uric acid stones beta, here we usually don't use a X-ray beta. Matlab you cannot them properly diagnose them on X-ray. That is important. Clear? Yes. Cystinuria में the patient will have a cola urine beta. Cystinuria में the patient will have a cola urine. Cystine, ornithine, lysine and arginine. Very good. Next, if they ask you beta what is the first line investigation, हमें पता है the first line investigation for a case of urinary stone is nothing else but X-ray KUB beta. Okay, X-ray KUB is going to be the first line and investigation of choice is NCCT KUB. Investigation of choice has to be NCCT KUB beta, that is what is important to be remembered. If they ask you X-ray KUB करोगे और अगर उस पे ऐसा पिक्चर दिखा, why it is the X-ray? Because we know beta, if it was a IVP or intravenous pylography, I should have been able to see the contrast in the ureter and bladder. As here there is no contrast in the ureter and bladder, it has to be a plain X-ray KUB. And on X-ray KUB, if something appears more white, then it is going to be either a calcification or a stone beta. Here the calcification is in the form of renal pelvis beta. And whenever there is a calcification in the form of renal pelvis on X-ray beta, we know it is nothing else but a classical presentation of Staghorn calculi beta. Let me know in the chat box, bache, that Staghorn calculi is definitely which kind of renal stone or urinary stone beta. Staghorn calculi will be which type of urinary stone. Which stone, when it grows very huge in size, will be called as the Staghorn calculi, bache. Let me know in the chat box. Which stone, when it grows very huge in size, is called as the Staghorn calculi. This is the picture of Staghorn calculi beta. Clear? Important is the next is the picture of nothing else but beta, a stone which is seen on the NCCT KUB. This is a picture of NCCT KUB where you are able to see a stone beta in the patient's kidneys, basically in the inferior calyx of kidney. You are able to see a stone beta. That is what is important to be remembered. Clear about? These are the points that you have to remember beta. We know that Staghorn calculi is nothing else but a type of which urinary stone. So Staghorn calculi is a type of basically nothing else but the triple phosphate stone. Very good. So triple phosphate or struvite stone which is there definitely beta, उसका type होता है Staghorn calculi. Now if they ask you what is the treatment, हमें पता है बेटा. Let's talk about renal stone. If I talk about renal stone बच्चे, so we know it depends on size. For example, let's say the size of renal stone is less than 5 to 6 mm. Whenever the size of renal stone will be less than 5 to 6 millimeter beta, we know we just go for an observation beta. Reason, as the stone is small in size, you will just go for an observation or a symptomatic management, that is give painkillers or analgesics, ask the patient to drink plenty of fluids beta, okay, and you can give syrups basically. Next important, if they ask you beta, whenever the stone is going to be more than 5 to 6 mm in size, हमें पता है whenever the stone is more than 5 to 6 mm in size, then what is the surgery? Let me know in the chat box. Whenever the stone in the kidneys is more than 5 to 6 mm in size beta, I hope all of you are quite aware, we tend to break down the stone into multiple pieces or multiple fragments beta with the help of the shock waves from outside bache. Okay, and in this condition, once the stone has been broken down into pieces or fragments, then it automatically comes out in the patient's urine beta. You just have to give plenty of fluids after the procedure. All the fragments will get excreted out in the patient's urine bache, and that procedure is classically known as nothing else but, yes, very good all of you, it is known as ESWL beta. What is ESWL? Extracorporeal shockwave lithotripsy beta. It is known as ESWL, known as extracorporeal shockwave lithotripsy. Now important is, please let me know if ESWL will be contraindicated, then what is the surgery of choice? If ESWL is contraindicated, like we know beta, if the female is pregnant for example, or if the stone is more than 2 centimeters in size beta, or if it is a cystine stone which is the hardest renal stone definitely which is, or whenever there is a distal obstruction. So whenever the stone is very big in size, more than 2 centimeters in size beta, or whenever there is a distal obstruction. Why? Because in case by ESWL, in case if you break the stone beta, okay, in case if you break the stone and after that if the fragments are not able to come outside due to distal obstruction, obviously that will cause more problem. So more than 2 centimeter का stone है, distal obstruction है beta, so then definitely we have to go for a better surgery, that is called as PCNL बच्चे. What is PCNL? It is percutaneous nephrolithotomy beta. That procedure is known as PCNL, known as a percutaneous nephrolithotomy बच्चे. That is important. Directly we go inside the renal pelvis beta or the kidneys and we have to extract the stone. That is PCNL surgery beta. Next important, if I talk about, is nothing else but ureteric stone bच्चे. If I talk about a ureteric stone beta, please remember that ureteric stone mein what is the treatment? Here we just go basically beta for a ureteroscopic removal in case if it is a large ureteric stone beta or if it is an impacted ureteric stone. Matlab, if that stone is very large in size, usually more than 5 to 6 mm, or if it is impacted, even if it is small doesn't matter, but if it is impacted, if it is obstructed, okay, if it is not coming out, then in those conditions we tend to go for a surgery. And I hope all of you are quite aware beta, the surgery that we do for a case of a ureteric stone is nothing else but URS, that is ureteroscopic removal of stone beta. And that ureteroscopic removal of stone which is there, which it is usually done with the help of which basket? The Dormia basket beta. Ureteroscopic removal of stone is usually done with the help of Dormia basket beta. That is what is important to be remembered. Clear about? Next important if they ask you which is nothing else but a case of bladder stone. अगर मैं bladder stone की बात करता हूँ तो we know bladder stone are usually removed by a procedure known as cystolithotomy. Bladder stone is usually removed by a procedure called as cystolithotomy. Now, when the size of the bladder stone is very small, I can go for a per urethral cystolithotomy. Per urethral matlab we will go via the urethra inside the bladder and we will extract the stone via the urethra. You will remove it via the urethra because it is small in size. But whenever the stone will be very big in size beta, obviously it is not possible to remove it via the urethra biche, and in those conditions you better go for a suprapubic cystolithotomy beta. In those conditions you go for a suprapubic cystolithotomy definitely, that is directly go inside the bladder and extract or remove the stone biche. Clear about? These are the procedures for stone removal beta from the urinary tract. Do remember them properly. Next important is a condition where the patient comes to you beta with a long history, around 4 to 6 months history beta, okay, and the patient is having lumbar pain, patient is having difficulty in urination at times beta, okay, and the patient is having now a decreased urine output or oliguria. If you have seen the picture, this is the classical picture beta. This is the X-ray again. Why X-ray? Because no ureter, no bladder. The X-ray पे something appears more white, matlab it is a calcification, and this time the calcification is in the shape of kidney. And whenever the calcification is in the shape of kidney, I hope all of you are quite aware, it is called as which kidney? Putti kidney beta. Whenever the calcification is in the shape of kidney, yaad rakhna, it is a classical case of putti kidney then. If they give you a similar picture beta, a lot of people are confused, always do remember that. If they give you a similar picture, but if they ask you, sorry, if they give you a similar picture and they give you a history beta, that the patient is having a low back ache, okay, then the patient is having a low back ache definitely, which and in that condition definitely patient is having signs of fever and all of that, then it is a diagnosis of which condition. ये तो पुट्टी किडनी है, चलो that is fine, but similar picture to this will come beta in your examination and they will say that the patient is not having any signs of TB beta, rather the patient is actually having low backache, along with that patient is actually having fever beta. What is the like? And the patient will have pain on extension of the hip. So whenever the patient tries to extend the hip beta or the leg, the patient will have a lot of pain. What is the diagnosis? Let me know in the chat box. So this is a case of putti kidney, and हमें पता है putti kidney is nothing else but renal tuberculosis. So whenever there is renal TB beta, initially we know which that first of all renal TB which is there, it is not a primary infection, it is a secondary infection. Matlab the patient is going to have the infection inside the pulmonary, like the patient is going to have a pulmonary tuberculosis from where the infection spreads to the genitourinary tract or to the kidneys beta. So renal TB or genitourinary TB is a secondary infection. Initially there is ulceration in the kidney, later on there is pus formation beta, and that pus formation is nothing else but pyonephrosis बच्चे. Pyonephrosis के बाद there will be putti kidney due to caseous necrosis. Putti kidney के बाद there will be a classical cement kidney which will be seen, and ultimately beta, okay, after the cement kidney the kidney will get completely damaged, that is called as autonephrectomy. We know beta autonephrectomy is a classical feature of renal TB. Let me know, autosplenectomy is seen in which condition? Autosplenectomy is seen in which condition? Very good, yes. A common differential for putti kidney on X-ray is going to be a calcified psoas abscess beta. Very good. So calcified psoas abscess जो होता है definitely that is a common differential that you have to remember. Okay, abscess inside the psoas muscle where patient has pain in the lower back and extension of the hip causes a lot of pain or worsening of pain. Similar presentation will be there. याद रखना PYQ था वो. Important is beta here if you do IVP or intravenous pyelogram, you are able to see that all the calyces have been damaged beta due to the renal TB, and the calyces which are damaged due to renal TB, they are classically called as moth-eaten calyces. Okay, that is classically known as the moth-eaten calyces beta. That is important to be remembered. The classical moth-eaten calyces will be seen. Very good. We know beta that autonephrectomy is a feature of renal TB, but autosplenectomy is seen in sickle cell anemia beta. Shabash. That is important to be remembered. Clear? Important is beta in cases of renal tuberculosis. We know what is the most important feature on the urine microscopic examination. I have told you, doesn't matter how big is the question beta, but that is the keyword of genitourinary tuberculosis or renal tuberculosis beta. What is that keyword? Let me know in the chat box. Genitourinary or renal tuberculosis में. Anybody? Genitourinary or renal tuberculosis में definitely the keyword on urine microscopic examination is nothing else but sterile pyuria. I have told you that. That is, your pus cells are going to be present in the urine beta, but obviously the bacteria is absent, and that's the reason we call it as sterile pyuria. That was the keyword of the question, definitely. Clear about sterile pyuria is the keyword in a patient of genitourinary tuberculosis. याद रखना है बस. Treatment if they ask you in cases. तो याद रखना बेटा, treatment in a patient of renal or genitourinary TB is nothing else but ATT beta, that is anti-tubercular therapy. Anti-tubercular therapy along with symptomatic management has to be done in a case of renal TB or genitourinary TB beta. Clear? Take a break of 15 minutes and then we will continue. Okay, once we are done with this part beta, that is the revision part, just 5 slides are left, then we will take the lunch break. Okay, so lunch break will be faster, I feel. मतलब ये जल्दी हो जाएगा, around by 1:30 itself I feel it would be over. So by 1:30 or 1:40 itself we can take the lunch break, and then after that, after the lunch break we will start with test and discussion. Clear? Hopefully all of you have attempted the test until now. ठीक है, तो प्लीज रिमेंबर, चलो. Let me know if the audio visuals are clear, bachcho. Let's start. Great, chalo. Next is a patient beta who presents to us with complaints of an abdominal mass and a painless hematuria. I've told you earlier also that whenever a patient comes to us with painless hematuria beta, think about renal cell carcinoma basically or about a bladder cancer. Okay? So think about either a renal cancer or a bladder cancer, because whenever there is hematuria, either due to stones or infections beta, both of them is going to cause pain. Painless hematuria is more classical of cancers, but cancers that is important. So here the diagnosis is more likely a case of renal cell carcinoma. If I talk about renal cell carcinoma, we know that it is going to be mainly an adenocarcinoma beta. Renal cell carcinoma, which is there beta, it is mainly an adenocarcinoma that you have to remember. Okay, adenocarcinoma is going to be the most common type over here. And we know that adenocarcinoma, which is there, it is going to arise from nothing else but the PCT, which is that is proximal convoluted tubule. The most common site from where the renal cell carcinoma originates, which is going to be the PCT, that is proximal convoluted tubule. If they ask you beta most commonly, okay, it is going to be with subtype. We know there are various subtypes of renal cell cancer. The most common subtype of renal cell carcinoma is the clear cell carcinoma beta. Barabar. So clear cell carcinoma is considered as the most common subtype of RCC. And yaad rakhna, this clear cell carcinoma is commonly associated with the VHL gene mutation or the VHL syndrome beta. And what is that VHL gene mutation or VHL syndrome? It is von Hippel-Lindau gene. So we know beta that definitely the clear cell carcinoma is commonly associated with the VHL gene mutation or the von Hippel-Lindau gene mutation beta. If they ask you best prognosis among all the subtype of renal cell carcinoma, beta, yaad rakhna that the best prognosis is usually seen with the chromophobe variety. So the chromophobe variety, which is there, the chromophobe type of renal cell carcinoma beta is going to have the best prognosis, whereas worst prognosis is usually seen with the Biliary duct cancer beta. So Biliary duct carcinoma, which is there definitely, or the collecting duct carcinoma, which is there beta, that Biliary duct type, which is there, it is going to have the worst prognosis among all the subtypes of renal cell carcinoma. Important is bache, if they ask you in patients of renal cell carcinoma, what is the investigation of choice? We know for liver for liver cancer, kidney cancer, pancreatic cancer, and for the gallbladder cancer, we usually don't take a biopsy beta. It is mostly a radiological investigation, and we know this radiological investigation that we do bache for all the retroperitoneal organs like kidney has to be CECT. So investigation of choice in patients of renal cell carcinoma is the CECT abdo beta, or a CCT abdomen has to be done. Important is if they ask you about treatment. Now, beta, treatment is nothing else but we have to remove the kidneys, that is called as nephrectomy beta. Now, whether we should go for a partial nephrectomy or a radical nephrectomy, that usually depends on the size of cancer. If they say the size of cancer is usually less than 4 centimeters, then we tend to go for a partial nephrectomy only. Whenever the size of cancer is less, that is less than 4 centimeter, we tend to go for a partial nephrectomy beta. But whenever they say that the size of cancer is more, whenever the size of cancer is more than 4 centimeter beta, we tend to go for a total or a radical nephrectomy. In that condition, we tend to go for a total or a radical nephrectomy beta. That is what is important to remember. Hopefully clear to all of you now. So less than 4 centimeter का cancer, go for a partial nephrectomy. More than 4 centimeter का cancer beta, go for a radical nephrectomy. That is what is important to be remembered. Hopefully clear. So these are the points that you need to remember basically for the renal cell carcinoma beta. Now if they ask you that which is going to be the most common renal malignancy in children. If they ask you beta the most common renal malignancy in children, I hope all of you are quite aware beta. It is nothing else but it is going to be a Wilms tumor beta, also called as nephroblastoma. हमें पता है that Wilms tumor or nephroblastoma is commonly seen in children who are less than 3 years of age beta. And this Wilms tumor or nephroblastoma is considered as the most common renal malignancy in children beta. Do remember this point. Okay. अब मुझे बताओ definitely that this Wilms tumor is commonly associated with syndrome. A syndrome where definitely there will be a hemihypertrophy in the child's body. There will be omphalocele. The child will also have macroglossia and Wilms tumor. What is that syndrome called as? Hemihypertrophy, omphalocele, macroglossia and Wilms tumor beta. What is that condition? Let me know in the chat box. पीडीएस से भी important है, PYQ है अगस्त का. तो Wilms tumor, if I talk about beta, we know it is the most common renal malignancy in children and second most common abdominal malignancy in children beta. Yes, that is important. Wilms tumor, definitely we know it is associated with multiple syndromes within the patient's body. Okay, histopathological examination, if you do in Wilms tumor, you will be able to find a mixed tumor beta. Now what do I mean by mixed tumor? Mixed tumor is nothing else but beta, you will be able to see blastomal elements, epithelial elements and even mesenchymal elements. The blastomal, epithelial and mesenchymal elements, if all of that is seen on the biopsy or the histopathological examination, biopsy we don't do, but for the histopathological examination beta, then that is the case of Wilms tumor. Which we know investigation is done just by CCT abdo beta, CCT abdomen can be done, and treatment which is there, definitely it is nothing else but bache, we have to go for a surgery. A nephrectomy surgery has to be done beta. Surgery के बाद definitely we have to go for a chemotherapy or radiotherapy beta. ठीक है, तो surgery के बाद definitely you should go for a chemo or radiotherapy depending on the stage of cancer. Early stages में we go for surgery followed by chemo only. Later stages में surgery followed by chemo radiation both. Clear? Very good. Beckwith-Wiedemann syndrome is the condition beta where all these features are going to be seen: Wilms tumor, omphalocele, macroglossia and hemihypertrophy. And Wilms tumor is very commonly associated with Beckwith-Wiedemann syndrome beta. Shabash. If they ask you bache that what is the most common abdominal malignancy in children, I have told you Wilms or nephroblastoma is the second most common abdominal malignancy. अगर पूछा जाए which is the most common abdominal malignancy in children, answer has to be a neuroblastoma beta. Right? So neuroblastoma is the most common abdominal malignancy in children, followed by your nephroblastoma, that is Wilms. Hopefully that's clear to all of you now. So do remember this. Okay? So neuroblastoma is going to be the most common abdominal malignancy in children beta. That is what is important. Hopefully clear. Chalo. Next important, let's talk about a case of nothing else but bladder rupture beta. Let's talk about nothing else but another case of bladder rupture. We know beta that urinary bladder is an extraperitoneal organ beta. So whenever urinary bladder ruptures, there can be two types. One, a extraperitoneal bladder rupture can happen or an intraperitoneal bladder rupture can happen. We know that more common is always an extraperitoneal bladder rupture. More common is usually a extraperitoneal bladder rupture. याद रखना, extraperitoneal bladder rupture happens due to a pelvic trauma or a pelvic fracture. Now due to a road traffic accident, whenever there will be a pelvic trauma or fracture, that will cause a extraperitoneal bladder rupture, also associated with a posterior urethral rupture beta. Yes, bladder rupture is very commonly associated with posterior urethral rupture as well. Whereas intraperitoneal bladder rupture or intraperitoneal urinary leakage will only happen whenever there is trauma to a full bladder or a over distended bladder. So whenever there is trauma basically to a full bladder, whenever there is a trauma to the full bladder or a over distended bladder beta, that condition is going to cause a intraperitoneal bladder rupture beta. That is important to remember. Clear about? Now here the patient is going to have problems like, first, the patient will have inability to pass the urine beta. Second, the patient is going to have bleeding that will cause blood at the tip of the external urethral meatus. So inability to pass urine and blood at the tip of the external urethral meatus will be commonly seen beta in both the types of bladder rupture. But additional feature in intraperitoneal will be, in intraperitoneal bladder rupture, as the urine leaks out into the peritoneal cavity, the patient will have high risk of peritonitis beta. So signs of some peritonitis are going to be classically seen whenever the patient has an intraperitoneal bladder rupture. Investigation of choice in both the condition is a CT cystography beta, where you have to inject a contrast inside the urinary bladder beta, and then you have to see the contrast leaking out on the CT scan. That is a CT cystography. We know that CT cystography is the investigation of choice for both extra as well as intraperitoneal bladder rupture. But we know CT cystography cannot be done when the patient is hemodynamically unstable. If the patient is hemodynamically unstable or if the patient is in shock beta, we tend to go for a X-ray. And when we inject a contrast and do a X-ray, that investigation is known as a cystogram beta. And when I do a cystogram, there are two kind of deformities as you are able to see. First one, यहाँ पे you can see beta that the contrast is leaking out into the pelvic cavity. Whenever the contrast leaks out in the pelvic cavity, the shape of the urinary bladder turns like a teardrop beta. And that teardrop deformity which is there, It is very classical of extraperitoneal bladder rupture. Teardrop deformity is a very classical feature of extraperitoneal bladder rupture. Second picture जो है यहाँ पे you can see the contrast leaking out into the peritoneal cavity, and whenever you see the contrast leaking out into the peritoneal cavity beta, you are able to see the classical sunburst appearance beta. And we know sunburst appearance which is there beta, it is a classical feature of intraperitoneal bladder rupture. So intraperitoneal bladder rupture which is there definitely on cystogram, it gives you a classical sunburst appearance which is that is important to be remembered. Clear? Next important if I talk about beta is the case of urethral rupture. Now when I talk about urethral rupture, basically we know the male urethra is divided into two parts beta, the anterior urethra which is made up of the penile and the bulbar urethra. Okay, the anterior urethra has two parts, the penile and the bulbar urethra, and second is the posterior urethra. Posterior urethra has two parts, membranous and the prostatic urethra, right? Posterior urethra has two parts, the membranous and the prostatic urethra. Important is हमें पता है that the anterior urethral rupture is much more common beta. Anterior urethral rupture is going to be much more common. We know anterior urethral rupture में the more common site to rupture is the bulbar urethra. बराबर? Anterior urethral rupture में the more common site to rupture is the bulbar or the perineal urethra, whereas posterior urethral rupture में the most common site to rupture is the membranous urethra beta. Posterior urethral rupture में the most common site to rupture is going to be the membranous urethra. Important is beta, we know that anterior urethral rupture which is there, it happens due to a perineal trauma. Now for perineal trauma, what they can give you a history of, first they can say the person has definitely stepped on a loose manhole cover. ढीला ड्रेनेज का जो ढक्कन होता है बेटा, ठीक है, on that loose manhole cover if the person steps, what is going to happen, that loose manhole cover will exactly go and hit between your legs beta in the perineum, causing a perineal trauma. Or a bicycle accident beta, I've told you, a rod wala bicycle, ठीक है. So definitely these conditions are known to cause a perineal trauma. which है posterior urethral rupture happens due to a pelvic trauma. We know na that bladder rupture and posterior urethral rupture both happen due to a pelvic trauma, like a pelvic fracture during a road traffic accident. In both the conditions beta, there are three features which are common bache. There is a classical triad which is seen in anterior and posterior urethral rupture. One is inability to pass urine beta. Obviously if the urethra is ruptured, the patient will have difficulty in passage of urine bache. Second, there will be blood at the tip of external urethral meatus. So there will be blood at the tip of the external urethral meatus. And third important, both these patients are going to have a hematoma beta. Due to bleeding, both these patients will have collection of blood called as hematoma. Now difference is only the location of the site. We know anterior urethral rupture mein, here the patient will have bleeding or a hematoma in the perineum. So there is a perineal hematoma in anterior urethral rupture. Whereas in case of posterior urethral rupture beta, there will be bleeding and hematoma in the pelvis, that is pelvic hematoma. So in cases of beta posterior urethral rupture, there is going to be a perineal hematoma, anterior urethral rupture there will be a perineal hematoma, and posterior urethral rupture there will be a pelvic hematoma. हमें बताएं investigation of choice in both the condition is the investigation called as RGU. What is RGU beta? Retrograde ureterogram, where I am going to inject a contrast inside the urethra beta, and then you can see the contrast leaking out bache on the X-ray. That is classically called as RGU, known as a retrograde ureterogram. That is the investigation of choice for anterior or the posterior urethral rupture. And if they ask you what is going to be the treatment beta, so very good, yes. So if they ask you definitely what is going to be the treatment bache, the treatment may we have to go for a suprapubic catheterization beta. Now why we have to go for a suprapubic catheterization? Definitely reason is when you go for a suprapubic catheterization beta, what is going to happen? Obviously drainage of bladder is going to happen. If the bladder is going to drain properly beta, if the bladder is going to drain bache, so obviously the urethra will get time to heal. If the bladder is directly drained with the help of a suprapubic catheterization or a suprapubic cystostomy, then obviously the urethra will not come in contact with the urine and it will get time to heal beta. That is important to be remembered. Now a PYQ bache, that is important to be remembered. Let me know about that in your examination beta, and that is in a case of anterior urethral rupture or in a case of perineal urethral rupture, urine collection or urine extravasation will occur at all these following sites except, ठीक है, anterior urethral rupture में urine extravasation happens at all these sites except options are superficial perineal pouch, second deep perineal pouch, third inner thigh, fourth anterior abdominal wall, fifth scrotum beta. तो superficial perineal pouch, deep perineal pouch, inner thigh, anterior abdominal wall, and the scrotum beta. Let me know in which condition, in which side there will be no urine collection. We know beta bladder rupture का treatment बाकी था. तो एक्स्ट्रा पेरिटोनियल ब्लैडर रप्चर अगर है डेफिनेटली, तो द ट्रीटमेंट इज ओनली अ सुप्राप्यूबिक कैथेटराइजेशन और सुप्राप्यूबिक सिस्टोस्टोमी. रीजन याद रखना बेटा, if you directly drain the bladder is going to heal automatically, it is going to spontaneously heal beta. You just have to drain the bladder with the help of suprapubic catheter beta, and the extraperitoneal bladder is going to heal on its own. You don't need a repair. But intraperitoneal है, तो we know बेटा intraperitoneal bladder rupture में तो patient is having peritonitis, and if there is peritonitis beta, we have to go for exploratory laparotomy. So whenever there is a peritonitis and intraperitoneal bladder rupture, always go for exploratory laparotomy beta. Along with that, do a peritoneal lavage properly to clean the peritoneum, and then go for a bladder repair beta. So exploratory laparotomy along with a bladder repair will be the treatment that we do for an intraperitoneal bladder rupture beta. Very good. So याद रखना definitely whenever they say बच्चे that the patient is actually having a anterior or a bulbar urethral rupture, we know beta that all the sites where there can be urine collection except the deep perineal pouch. Deep perineal pouch where the urine doesn't collect in anterior but rather collects in the posterior urethral rupture beta. Very good, shabash. Next important is this question over here. It states beta, we are having a neonate bachche who was brought to the ER or the emergency room beta, and the child was having complaints of urinary retention beta. Child was diagnosed with a case of complete PUV. What is PUV? Posterior urethral valve. So I hope all of you are quite aware beta. In this male urethra, sometimes what happens beta, in the posterior urethra there is this kind of a valve, and this is a one-way valve beta or a unidirectional valve which will not allow the urine to come outside bachche. So either it could be a complete valve or a incomplete valve beta, and this valve की वजह से the person is not able to pass urine properly, causing urine retention, and due to that urine retention the child can definitely have beta pain or infections or stones as well at times. Apart from that, as the child is having a valve which is not allowing the urine to come outside, either the child is not able to pass the urine or the child has a very poor stream of urine beta. That is important to be remembered. Clear? So yaad rakhna, here also the neonate was brought to us with a case of complete posterior urethral valve, and that's the reason why the child was not able to pass urine bachche, causing urinary retention bachche. Investigation of choice should be what, anybody, in this case? We know two conditions: vesico-ureteric reflux, when there is backflow of urine from bladder into the ureters, and second, posterior urethral valve. In both these conditions, the investigation of choice has to be MCU. MCU is nothing else but micturating cystourethrogram. What is that? We have to inject or we have to fill in the bladder beta with a lot of contrast, and once the bladder is full, then the patient will start urinating, and once the patient urinates beta, you will definitely take the x-rays. That is called as MCU or a micturating cystourethrogram. So here definitely when you do a micturating cystourethrogram beta, you are able to see this classical picture over here. Which kind of appearance is seen? You are able to see a classical appearance over here beta called as the keyhole appearance. Now whenever there is a ultrasound or of MCU beta showing me a keyhole appearance, we know it is a case of posterior urethral valve. Another question from keyhole, ENT say, let me know beta, keyhole glottis is a feature of which condition? Keyhole glottis is seen in which condition beta? Let me know. So keyhole appearance, so we know it is a case of posterior urethral valve beta. Keyhole glottis किस में दिखता है? Let me know. So we know whenever a patient is going to have a posterior urethral valve, the child will have urine retention beta. And as the child will have urine retention, emergency treatment which is there beta, it is nothing else but insertion of Foley's catheter. Will this valve allow Foley's catheter to insert? Yes beta. Reason, this is a one-way valve. It will not allow the urine to come outside. But if you try to insert a Foley's catheter, that Foley's can easily go inside beta. That is what is important. Okay? So Foley's catheterization is going to be the first step, okay, or the emergency management to drain the retained urine in a patient of posterior urethral valve beta. That is what is important to be remembered. Clear about? So do remember this. No issues with this, anybody? Clear? So this is what is important to be remembered beta. We are right now, keyhole glottis is a feature of phonesthenia. Yes, very good. Yes, Shabash. So phonesthenia, when there is a weak adductor muscle beta, then there is gap between the vocal cords called as keyhole glottis. तो उसमें there is a keyhole glottis beta phonosthenia में. Next important, if I talk about definitive management, हमें पता है definitive management is nothing else but TURV beta, and when I say TURV, it is nothing else but transurethral resection of valve beta. Okay, or nowadays so we can also do fulgration of valve. So surgically I can definitely resect out the valve beta which is present in the posterior urethra, or nowadays so we can also do fulgration of this valve beta with the help of laser. That is what is important to be remembered. That is the procedure of choice which in patients of posterior urethral valve beta. Yeah. Next important, if I talk about, we know beta, normally the urethral opening is exactly in the front of the penis beta. But here, if the urethral opening is not in the front of penis, if it is on the ventral surface or the down surface of the penis beta, that is what is called as hypospadias beta. ठीक है, तो hypospadias is nothing else but whenever the urethral opening is on the under surface or the ventral surface of the penis, that is hypospadias. हमें पता है बेटा hypospadias की बात करेंगे तो the most common and the least severe type which is there, it is the granular variety. बराबर, हमें पता है बेटा the most common as well as the least severe variety. Why least severe? Because in granular variety beta, the urethral opening is just below the normal opening, so it doesn't cause many problems beta. So please remember, granular variety is the most common but the least severe variety of hypospadias, whereas the perennial variety which is there, that perennial variety is the least common variety of hypospadias. So perennial is the least common but the most severe variety of hypospadias beta. Perennial is the least common but the most severe variety of hypospadias beta. That is important to be remembered. Clear? हमें पता है in patients of hypospadia sometimes there can be a downward curvature of penis also. That downward curvature of penis associated with hypospadia is called as chordae beta. So patients of hypospadia sometimes can also have a chordae. Apart from that, they will have a downward stream of urine. Normally there should be a forward stream of urine beta, but in condition में there will be a downward stream of urine definitely. That means the patient says, Doctor साहब urine falls on my feet itself. पैरों पे urine गिरती है. That is a classical feature of hypospadias. हमें पता है in patients of hypospadias there is not only problems with the urination, the patient will even have problems with sexual intercourse also beta. That is important. If they ask you about hypospadias, treatment क्या होगा? So we know beta, treatment for a hypospadias case is nothing else but urethroplasty बच्चे. तो chordae correction के लिए you will do a orthoplasty, but for the repair of the urethra we have to go for a urethroplasty. याद रखना that urethroplasty is done usually beta using the foreskin or the prepuce as the graft. So foreskin or the prepuce is going to be used as the graft beta, and then you perform this urethroplasty procedure. So please tell me, if foreskin has to be used as a graft, if foreskin has to be used as a graft, which procedure is contraindicated if a child is suffering from hypospadias? Let me know in the chat box which procedure sorry, which procedure should be contraindicated if the child is suffering from hypospadias beta, if you need the foreskin or the prepuce for reconstruction or urethroplasty. Let me know. Bolo. Which procedure should be contraindicated? Anybody? We know beta that whenever you will need the foreskin definitely for a urethroplasty procedure, that is the reason the excision of the foreskin, that is circumcision, has to be contraindicated. Very good. So circumcision is contraindicated beta in all those patients who are suffering from hypospadias, because you will need the prepuce or the foreskin for reconstruction, which that is important. Shabash. Chalo. Next is a PYQ in your examination beta, repeated twice almost. A neonate was delivered preterm beta. Okay, neonate was delivered preterm. On examination, his scrotal sacs were empty beta. The scrotal sac of this baby were empty. So sorry. The scrotal sac of this patient were empty beta. So an ultrasound was performed, and that ultrasound reveals that the right sided testis which is there, it is inside the inguinal canal beta, and the left sided testis, so the left one is in the iliac fossa. Please tell me definitely beta sorry, what should be the likely diagnosis beta? What should be the likely diagnosis? Anybody? Bolo. Anybody? Right sided testis is undescended or ectopic? यहाँ पे देख सकते हो बेटा, they are saying that the right sided testis which is there beta, it is inside the inguinal canal. We know whenever the right sided testis is in the inguinal canal, that means definitely beta the right sided testis is undescended. Shabash. Right sided testis is undescended beta, whereas we know that the left sided testis which is there beta, the left sided testis which is there beta, it is in the iliac fossa. And when the left sided testis will be in the iliac fossa beta, we know that the left sided testis is going to be ectopic in nature. Okay, left sided testis is ectopic in nature beta, that is important to be remembered. Clear about? Yeah, now why? Reason we know what is undescended testis. Undescended means we know that usually testes are going to develop inside the abdomen, and once the development of the testis is completed between 7 to 9 months of intrauterine life, between 7 to 9 months of intrauterine life beta, these testes go down inside the scrotal sac. That is called as descent. But whenever the testis will get arrested in the normal path of descent, that is undescended testis beta. Important is basically that undescended testis or cryptorchidism is only said when the testis is arrested in the normal path. And what is normal path? Abdomen, inguinal canal, and scrotum. If the testis is arrested anywhere over here, abdomen, inguinal canal, or scrotum, then it is undescended. But outside this will always be an ectopic testis. Iliac fossa is not the normal path of descent, so it will be ectopic. Clear? Undescended testis की अगर मैं बात करूँ बेटा, it is more commonly seen on which side? Anybody, right or left side? याद रखना, undescended testis is more common on the right side because the right sided testis descends late. Most common cause of undescended testis beta, we all know it is idiopathic बच्चे, we don't know. ठीक है, तो please remember idiopathic is the leading cause for an undescended testis beta. That is important to be remembered. Most common site, I hope all of you are quite aware, it is inguinal canal. The most common site basically beta for the undescended testis or for a cryptorchidism beta is nothing else but inguinal canal beta. That is important to be remembered. ठीक है. If they ask you now in this patient what is the investigation of choice, हमें पता है बेटा investigation of choice is usually an ultrasound. ठीक है. Please remember ultrasound will help you to make a diagnosis of undescended testis if the testis is arrested in the inguinal canal. But if the testis is arrested somewhere else beta, then ultrasound will not help you to make a diagnosis. Then definitely beta the best investigation to make a diagnosis will be laparoscopy बच्चे. Then the best investigation to make a diagnosis will be laparoscopy. Anybody let me know beta, whenever a child suffering from undescended testis is brought to you beta, whenever a child suffering from undescended testis is brought to you before 6 months of age, what is the treatment of choice? So child of undescended testis less than 6 months of age, what is the treatment of choice? Let me know in the chat box. बोलो. Anybody? Whenever a child is less than 6 months of age beta has been brought to you, definitely the treatment of choice is going to be, whenever the child is less brought to you, definitely it is only observation or reassurance beta. Okay, the treatment is only observation or reassurance beta, no treatment is done. Reason is majority children may definitely beta the descent of testis will spontaneously occur between 6 to 9 months beta. Majority बच्चों में the testis का descent is going to happen on its own beta up to 6 to 9 months of age. इसीलिए before 6 months we don't treat the child beta. That is what is important to be remembered. Clear है बात? So that has to be kept in mind. If the child is definitely बच्चे between 6 to 18 months of age beta, याद रखना whenever the child is going to be between 6 to 18 months of age, definitely then you can go for surgery. Previously it was 6 to 12 months. Now the best time for surgery is 6 to 18 months beta, and in this condition I can go for an orchidopexy. That is, you have to search where is the testis lying, and once you have found out, then you have to bring that testis down beta and you have to fix it basically, and that fixation is known as an orchidopexy. The best time for orchidopexy is definitely beta, okay, 6 to 18 months. Please remember ultrasound will be the investigation of choice beta at the inguinal canal. Matlab whenever there is a testis and testis arrested in the inguinal canal, ultrasound can help you make a diagnosis. But anywhere else, matlab in the abdomen or anywhere else, if the testis is there beta, then ultrasound is not going to help you. Then you need a laparoscopy in those conditions. Clear? Sorry. Next is a case of nothing else but hydrocele beta. If I talk about hydrocele, basically what is hydrocele? Hydro means fluid, right? So we know beta hydrocele का मतलब होता है whenever there is fluid collection inside the scrotal sac. So whenever there will be fluid collection in the scrotal sac beta, obviously the patient will come to us with a lot of heaviness definitely, okay, or a lot of heaviness, dragging sensation or swelling inside the scrotum. As you're able to see, the patient will be brought to you with a lot of heaviness, dragging sensation and swelling in the scrotum beta. Okay, we know there are various types of hydrocele बच्चे, but the most common variety of hydrocele is going to be vaginal hydrocele. Most common type of hydrocele definitely beta is going to be vaginal hydrocele. That is important to be remembered. Clear about? If I talk about vaginal hydrocele, what is the feature over here? Here there is only and only fluid collection inside the scrotum beta. Okay, when the fluid collection is limited to the scrotal sac, it is called as vaginal hydrocele. In infantile hydrocele, there is collection of fluid in the inguinoscrotal region. Whenever there is collection of fluid in the inguinoscrotal region, then that is infantile hydrocele. And when there is a connection directly with the abdomen, matlab not only fluid collection in the scrotum and inguinal region, but even there is a connection with abdomen beta, that is a congenital hydrocele. Clear about? Important is whenever the patient comes to you, definitely. Sorry, most common type which is there, it is vaginal hydrocele. Most common cause if they ask you beta, तो याद रखना definitely the most common cause is idiopathic. Most common cause in case if they ask you for hydrocele, it is idiopathic. याद रखना the primary hydrocele which is there, it is mainly idiopathic in nature, but secondary hydrocele can be secondary to infections beta, and secondary hydrocele develops due to infections like, let me know in the chat box, secondary hydrocele basically which it develops due to infections like which one? Which condition develops a secondary hydrocele? Let me know in the chat box which infection. So here, as the patient has come to us with a complaint of either a scrotal swelling beta or an inguinoscrotal swelling, we definitely palpate the swelling, and after that we will flash a torchlight in the swelling. And when you can see beta, we have flashed a torchlight, the whole swelling brilliantly glows with light beta, and this is called as transillumination test positive. So we know that hydrocele is one of those 4 swellings in the body beta where the transillumination test will be brilliantly positive. The transillumination test is brilliantly positive for hydrocele, ranula, cystic hygroma, and meningocele. Hydrocele, ranula, cystic hygroma, and meningocele beta. Important is definitely over here you have to remember one more thing, and that is investigation of choice. We know beta, it is just a fluid collection basically, and as it is a fluid collection bache, therefore you just have to go for an ultrasound scrotum. So ultrasound scrotum will be the investigation of choice bache in a case of a hydrocele. That is what is important to be remembered. Okay, that is important. Yes, very good. Lymphatic filariasis or a Bancroftian filariasis is the infection which can increase the risk of hydrocele beta. That is important. Shabash. Treatment की अगर मैं बात करूंगा बेटा, we know that if it is a small hydrocele beta, so what we do in small hydrocele, I've told you, we just make an incision over the sac. Once we have made an incision over the sac, I drain all the fluid collected in the sac, and after draining all the fluid in the sac, then we open up the sac beta and we suture the margins on the sides. When we suture the margins on the sides basically beta, this procedure is classically called as Lord's plication surgery. ठीक है, तो जब भी small hydrocele होगा बेटा, we tend to go for a Lord's plication surgery, which is similar to marsupialization, you can say, right? Whereas if I talk about a large hydrocele beta, do you remember large hydrocele mein what we do? If there is a large hydrocele, again I make an incision over the sac. Once I have made an incision and open the sac beta, then I drain the fluid. After draining all the fluid which is collected beta, then I am going to evert the sac. When you evert the sac beta, then you are going to suture the sac posteriorly bache. Okay, therefore no fluid collection occurs again, and that is classically known as which procedure? Let me know in the chat box. The large hydrocele, where I do a eversion of sac and then suture the sac completely beta. It is classically known as which procedure? I hope all of you are point out. This was a PYQ. It is known as the Jabulais surgery or the Jabulais procedure beta. It is classically known as the Jabulais surgery or the Jabulais procedure. Do you remember that? Hopefully clear to all of you now. Chalo. The next one, if I talk about beta, is nothing else but a case of priapism. Now, when I talk about priapism, priapism is what? Priapism is nothing else but a prolonged painful penile erection beta. So we know it is a prolonged painful penile erection lasting for how many hours beta? So priapism definitely is a prolonged painful penile erection lasting for how many hours? Let me know in the chat box. Let me know in the chat box. This was a PYQ. Priapism is a prolonged painful penile erection lasting for how many hours? More than how many hours? We know the leading cause of priapism is nothing else but idiopathic beta. Again, the leading cause of priapism is idiopathic or unknown bache. Secondary cause can be there, and the most common secondary cause is going to be trauma beta. So trauma during an over enthusiastic sexual intercourse, I've told you beta. So that trauma basically is the leading secondary cause of priapism. Most common cause in children, another previous year question from NEET and has been asked in FMG exam also beta. So sickle cell anemia which is there, that sickle cell anemia is the leading cause of priapism in children. ठीक है, तो याद रखना सिकल सेल अनीमिया विच इज देयर बच्चे, इट इज द लीडिंग कॉज ऑफ प्राइपिज्म इन चिल्ड्रन. दैट इज इंपॉर्टेंट बिकॉज द सिकल्ड आरबीसीज ब्लॉक द पेनाइल वेसल्स बेटा. वेरी गुड. तो वेन एवर द penile erection which is painful, it is lasting for a span of more than 4 hours बच्चे, that is considered as priapism. Very good. ट्रीटमेंट अगर पूछेंगे, हमें पता है प्रायपिज्म और पेनाइल इरेक्शन हैपेंस व्हेन देयर इज मोर ब्लड फ्लो टू द पीनस बेटा. तो इफ यू हैव टू ट्रीट दैट, ऑब्वियसली यू हैव टू एस्पिरेट द ब्लड from the penile vessels or from the corpora cavernosa beta. The aspiration of blood or removal of the blood has to be done from the penile vessels or the corpora cavernosa. That is going to be the treatment which is in a patient of priapism beta. That is what is important to be remembered. Clear? Next important is a case जहाँ पे we are having a 15-year-old male beta. This patient who is a 15-year-old male presents to you with a complaint of sudden, along with sudden beta, it is a severe scrotal and abdominal pain. ठीक है, it is sudden onset but it is very severe scrotal and abdominal pain beta. And on elevating the scrotum beta, on elevating the scrotum, definitely the patient's pain which is there beta, it has not been relieved. On elevating scrotum, patient's pain is not relieved beta. What is the likely diagnosis? Anybody let me know. Scorpion bite can cause it but it is not the leading cause, right? That is important. Leukemia is rather a more common cause than scorpion bite. So please definitely beta do remember, definitely there will be 10 to 25-year-old patient beta. There will be a 10 to 25-year-old patient definitely who is going to have, okay, 10 to 25-year-old patient which is there beta is going to definitely have a pain in the scrotal region beta, along with that the abdomen beta, and the patient may have other features like nausea, vomiting, fever. So definitely as the patient is having pain and other signs of inflammation beta, it seems to be a case of epididymoarthritis. Okay, now whenever I have to differentiate between epididymoarthritis and testicular torsion, I perform a clinical test when I just lift up the scrotum or I just elevate the scrotum. After lifting up the scrotum or supporting the scrotum, if the patient's pain is relieved bit, अगर दर्द ठीक हो जाता है, then it is a case of epididymoarthritis because it was an inflammatory pain and therefore it has got relieved after support. But in cases of testicular torsion beta, even when I lift up the scrotum, even when you elevate the scrotum, pain is not relieved, rather the pain worsens beta. Clear? So the pain is not relieved or rather the pain worsens definitely whenever it is a case of testicular torsion. So as here they are saying beta, the patient on elevating the scrotum beta, pain is not relieved or rather the pain worsens. That means we know it is a case of testicular torsion beta. And what happens in testicular torsion? We know beta, testicular torsion may either the spermatic cord which is there or the testis which is there beta, it undergoes a twisting or malrotation. And whenever the testis or the spermatic cord undergoes twisting or malrotation, obviously the blood supply of the testis is going to suddenly stop. And if the blood supply of testis stops beta, it may undergo ischemic necrosis. And whenever there will be a ischemic necrosis of the testis, there will be a non-viable testis which will be seen. Clear about? So that is what is important to be remembered about testicular torsion. Important is, if they ask you beta in patients of testicular torsion now, okay, what is the investigation of choice? याद रखना, testicular torsion doesn't need any kind of investigation. Why? Because testicular torsion is usually a clinical diagnosis beta. I don't need any investigation. Okay, I can just do a clinical diagnosis of testicular torsion beta and I can immediately go for the treatment बच्चे. ठीक है, तो clinical diagnosis में you will see the symptoms and to differentiate basically beta with the epididymoarthritis, the test that we performed of lifting up the scrotum, that test was classically known as the French test. To support our diagnosis, I can just go for an ultrasound scrotum. Ultrasound scrotum can be done better if it is available, and that is just to support our diagnosis or to see the vascularity of the testis. That's it. Okay. Important is testicular torsion mein, as the testis has undergone torsion, we immediately start exploring beta. And once you start exploration, if you find that the testis is viable, see, when the patient might have come to us earlier beta within 6 hours, then 100% the testis is viable, it has not undergone necrosis. I can save the testis. Kya karoge? Obviously, whatever testis has undergone a torsion beta, just derotate the testis, bring it into the original position, and after bringing it into the original position, then try to fix it by orchidopexy beta. then derotate the derotate the testis and perform an orchidopexy. That is what is the important thing. Clear? If the testis is non-viable, beta, if the testis is actually non-viable, definitely. So please remember, beta, whenever the testis is non-viable or it has undergone necrosis, we know if the testis has undergone necrosis, beta, we have to do an orchidectomy. I cannot keep a necrosed testis, beta. That is what is important. So if the testis is viable, then obviously we have to perform an orchidopexy. And whenever the testis is non-viable, then we have to go for an orchidectomy. Now, whether you perform an orchidopexy or orchidectomy in the affected testis, beta, I hope all of you are quite aware that in the opposite side or the contralateral side, you have to immediately do an orchidopexy, beta. In the same sitting or in the same surgery, which make sure that you are also going to fix the opposite sided testis. Otherwise, the patient will have a risk of opposite sided testicular torsion, beta. That is the reason. Clear? Chalo. Next is a case, beta, of a varicocele. Now, what is a varicocele, which we know when the testicular vessels which are there, beta, they will get dilated and will become tortuous, beta. We know in testis there is the pampiniform plexus of veins. Whenever there is pooling up of blood inside this pampiniform plexus of veins, beta, and whenever this pampiniform plexus of veins will get dilated and they will become tortuous, beta, that is basically called as varicocele, because varices means dilated and tortuous vessels. Barabar. So varicocele is more commonly seen on which side, beta? Let me know. Varicocele is seen on which side? Definitely let me know. Anybody? Please tell me, beta. Varicocele is more commonly seen on which side? Definitely. So we know, beta, varicocele happens when the testicular veins or the pampiniform plexus of the veins is not able to drain the blood properly and there is pooling up of blood, beta. Okay, most common cause is idiopathic here also, beta. The leading cause of varicocele is again idiopathic, beta, or unknown. Pendulous scrotum though can increase the risk, beta. Okay, most commonly it is always seen on the left side, shabash, because we know, beta, that the left sided testicular vein which is there, it drains into the left renal vein, and whenever the left testicular vein drains into the left renal vein, it drains at a 90 degree or a perpendicular side, beta. It drains at 90 degree, therefore it is not able to empty itself properly, and that can cause pooling up of blood in the left pampiniform plexus of testicular veins, causing varicocele. We know varicocele means as there is pooling up of blood, beta, the patient will have a sensation. The patient will have a sense of heaviness basically inside the scrotum. So there will be a sense of heaviness. Along with that, the patient will always have a constant dragging sensation. मतलब ऐसा लगता है कोई नीचे खींच रहा है बेटा. The person experiences or the person feels as if somebody is pulling the scrotum down. Important is when you palpate the testis, beta, you are able to get a very classical appearance known as bag of worm, beta. Right? The bag of worm feel is going to be seen. Anybody, bunch of grape appearance किस में दिखता है? Anybody? When you palpate the scrotum, beta, and you are able to get a bunch of grape appearance. That is a classical feature of which condition? Let me know in the chat box. So bag of worm feel definitely when you palpate these dilated testicular vessels, beta. That is seen usually in a case of varicocele, beta. That is important to remember. Clear? If they ask you, definitely in patients of varicocele, as it is a problem related, beta, to the scrotal sac. So therefore, investigation of as it is a problem related basically, beta, to the vessels. So here we go for a color Doppler. Okay. So color Doppler which is there, beta, it is the investigation of choice in patients of varicocele. And treatment of choice agar पूछेंगे beta, तो obviously the treatment of choice is nothing else but initially if the patient comes to us in early stages, I can just go for an angioembolization. Early stages mein, तो I can just go for an angioembolization, beta. But later stages mein, we can definitely go for, see, angioembolization is the initial management. If that doesn't help, beta, go for surgical ligation. If surgical ligation also doesn't help, you can also have an alternative, that is sclerotherapy. So angioembolization, sclerotherapy, surgical ligation, these are the things that are done initially, beta. But if none of them help, then the best option is always varicocelectomy, beta. The best option is definitely varicocelectomy, which is, that is what is important. Hopefully clear to all of you now. Yeah, the best option is always a varicocelectomy, beta. That is important to do. Clear? So याद रखना, bunch of grape appearance is usually seen in cases of epididymal cyst, beta. When there is an epididymal cyst, that causes basically a bunch of grape appearance. ठीक है? Next important is testicular tumors, beta. If they ask you about testicular tumor, please remember, beta, that the most common testicular tumor that we have in children is going to be the yolk sac tumor. The most common testicular tumor definitely we have in children is yolk sac tumor, beta. Yolk sac tumor, we all know beta, the tumor marker is alpha fetoprotein or AFP. So yaad rakhna that the testicular tumor in children which is there beta, that is yolk sac tumor, it is AFP positive or alpha fetoprotein positive. If they ask you beta which bodies are going to be seen, let me know. Histopath of yolk sac tumor, you might have studied in gynae also. Histopath basically of yolk sac tumor which is there beta, it will show you classically which bodies beta. Let me know in the chat box. Next important is adults mein the most common testicular tumor overall, or the most common testicular tumor in adults beta, answer would be a seminoma. The most common testicular tumor in adults or overall is a seminoma. Do remember, seminoma is not a benign tumor. Seminoma is a malignancy. Though it is a oma, yaad rakhna seminoma is going to be a malignancy beta. That is important to be remembered. Clear? Seminoma which is there beta, it is AFP negative. Yaad rakhna, a lot of people are saying that AFP positive. No. Classical seminomas are always AFP negative or alpha fetoprotein negative. So the tumor marker for seminoma is LDH beta, lactate dehydrogenase. Lactate dehydrogenase is actually the tumor marker बच्चे for a seminoma. That is important to be remembered. Clear है बात? याद रखना है बात. This is important to be remembered. Very good. याद रखना yolk sac tumor में histopathological examination shows you the classical Schiller-Duval bodies beta. The classical Schiller-Duval bodies will be seen on the histopath of a yolk sac tumor. Okay. Next important, if they ask you beta elderly patient, if they ask you definitely about the elderly patient बच्चे, तो elderly patient जो होता है, in this patient the most common testicular tumor is lymphoma. The most common testicular tumor in elderly patient is lymphoma beta, and we know most common bilateral testicular tumor is also lymphoma. Most common bilateral testicular tumor is also lymphoma बच्चे. Please tell me beta, what is the investigation of choice for testicular tumor? Let me know in the chat box what is going to be considered as the investigation of choice for testicular tumor beta. So investigation of choice in patients of testicular tumor, let me know in the chat box. Treatment, we all know beta, basically it is nothing else but a high inguinal orchidectomy, right? Here you have to make an incision in the inguinal region beta, not on the testis, or sorry, not on the scrotum, and directly remove the testis from there beta. So high inguinal orchidectomy which is there, it is considered as the treatment of choice in a patient of testicular tumor. So testicular tumor mein the treatment of choice, if they ask you, answer is a high inguinal orchidectomy. Investigation of choice for the testicular tumor, answer would be investigation of choice for testicular tumor, answer is going to be what? Yes, very good. The investigation of choice for testicular tumor beta is usually an ultrasound beta, right? So ultrasound scrotum is definitely done to diagnose the case of testicular tumor. CCT abdomen is done to see the lymphatic metastasis. Okay, so ultrasound is the investigation of choice along with tumor markers beta. So ultrasound along with tumor markers will be the investigation of choice beta. What is absolutely contraindicated, we know beta. So yaad rakhna, the procedure that is absolutely contraindicated in patients of testicular tumor is FNAC or biopsy beta. We know whether it is a transscrotal FNAC or it is a transscrotal biopsy beta. It is going to be absolutely contraindicated if the patient is having a testicular tumor. Transscrotal FNAC or biopsy is absolutely contraindicated in testicular tumor. That is important to remember. Yeah. So next important, if I talk about beta, is the last part from uro, and that is nothing else but the prostate beta. If I talk about the prostate gland, there are two problems. One is BPH, benign prostatic hyperplasia, and second is prostate cancer. Now, what is the BPH or benign prostatic hyperplasia? यहाँ क्या होता है बेटा? Here definitely the prostate gland is going to enlarge. And if the prostate gland enlarges too much, basically beta, what is going to happen? Obviously the prostatic urethra gets compressed, and whenever the prostatic urethra gets compressed beta, the patient is not able to pass the urine bache. Whenever the patient will not be able to pass the urine, the patient will develop lower urinary tract symptoms known as LUTS beta. Lower urinary tract symptoms like patient may have hesitancy, intermittency, increased urinary frequency, urine retention, overflow incontinence. ठीक है, तो all of these features which are there basically beta, they are called as together LUTS, lower urinary tract symptoms. Clear? So whenever there is a benign prostatic hyperplasia or enlargement of prostate gland, these problems are seen. We know beta that definitely BPH is more commonly seen in older patients basically beta, that is more than 50 years of age. Okay, so more than 50-year-old patients definitely beta, like more than 50-year-old patients, but definitely we are able to see this condition beta, that is a problem. Okay, more than 50-year-old patients mein BPH is commonly seen. Most common site, if they ask you, it is the transitional zone of the prostate gland. We know beta most common site definitely is the transitional zone of the prostate gland beta. That is important to be remembered. So transitional zone of the prostate gland is going to be considered as the commonest site बच्चे for a BPH or a benign prostatic hyperplasia. We know BPH के patient में, as I told you, the patient will complain of the LUTS beta, that is lower urinary tract symptoms. ठीक है. Now in this condition, investigation of choice is nothing else but an ultrasound beta. We know that investigation of choice which we do in patients of BPH beta, it is nothing else but an ultrasound beta. But along with ultrasound, how to confirm the diagnosis? Anybody? Along with ultrasound, how to confirm the diagnosis? Anybody let me know? Because ultrasound will only tell me beta that okay, the size of prostate has enlarged, and second, that the post void residue is more than 100 cc beta. So whenever the size of prostate is enlarged and the post void residue is more than 100 cc, we know that the prostate gland has been enlarged beta over here, and that is a case of BPH or prostate cancer. Because in both the conditions, the prostate gland will be enlarged beta. In both the conditions, the patient will have a significant post void residue. So how to differentiate whether it is a case of BPH or it is a case of prostate cancer beta? How to differentiate that apart from ultrasound? Ultrasound cannot give me a proper difference. Anybody? I hope all of you are quite aware beta that prostate cancer definitely may. We are going to check the level of PSA. Very good. We will check the level of PSA beta. We know that PSA is a prostate specific antigen, which is a tumor marker beta. So PSA levels are going to be beta normal or very mildly elevated if a patient is suffering from BPH, but the PSA levels are grossly elevated beta, more than almost 10 nanogram beta, when the patient is actually suffering from a case of nothing else definitely beta but a prostate cancer. So normal or slightly elevated in BPH but grossly elevated in patients of prostate cancer. Drug of choice की बात करें तो we know initial management of BPH is always medical management, and the drug of choice that we use beta is nothing else but tamsulosin. The drug of choice that we give in patients of BPH beta is drugs like tamsulosin or silodosin beta. We know that tamsulosin or silodosin are selective alpha 1A blockers beta. So drugs like tamsulosin or silodosin which is there, these are drugs like alpha 1A blockers. They will only increase the urinary outflow beta, okay? But the drugs like prazosin or terazosin beta, the drugs like prazosin, terazosin, which are alpha 1 blockers, they don't only increase the urinary outflow beta, they also decrease the blood pressure of the patient. They cause hypotension. Therefore, let me know beta, in which patients of benign prostatic hyperplasia or in which patients of BPH beta, prazosin like drugs are going to be the drug of choice. In which patients of BPH beta, prazosin like alpha 1 blockers are the drug of choice. Let me know in the chat box. Along with that, definitely बच्चे, here we also have to give a drug which will decrease the size of prostate. याद रखना, this is not a drug of choice now, but yes, it is given to decrease the size of prostate, and that is finasteride. We know finasteride is a 5-alpha reductase inhibitor beta, which can be given alongside. Drug of choice is always tamsulosin बच्चे, that is important to remember. Plus along with that we can give finasteride beta to decrease the size of prostate. Very good. So we know beta, whenever a patient is having BPH along with hypertension, then definitely the drugs that we can give are prazosin or terazosin like drugs which are alpha 1 blockers beta. Shabash, that is important. Treatment of choice. We know beta, treatment of choice for BPH is nothing else but TURP beta. When I say TURP, TURP is nothing else but transurethral resection of prostate. So the transurethral resection of prostate beta, or the transurethral, okay, fulgura, like resection or ablation of prostate which is done beta, that is basically called as TURP surgery, and that is considered as the drug of choice definitely beta in this patient. Clear? Chala. Next important, if I talk about, is a case of nothing else but prostate cancer. We know beta that the prostate cancer is the most common cancer in elderly males beta. It is the most common cancer definitely in elderly males, which is, that is important to remember. More than 50 years of age mein, most common cancer is always prostate cancer. If they ask you beta most common site, we know BPH is more commonly seen beta in the transitional zone, but prostate cancer is more common in the peripheral zone beta. Prostate cancer is more commonly seen in the peripheral zone, that is important to remember. याद रखना है बात. Okay. Prostate cancer is more commonly seen in the peripheral zone. If they ask you beta screening कैसे करते हो, we know beta the best method of screening which is there. The best method of screening which is there, it is combination of two things. One is serum PSA or serum prostate specific antigen, which is a tumor marker, along with digital rectal examination. So serum PSA plus digital rectal examination is considered as the best method of screening beta. PSA plus DRE is the best method of screening. ठीक है, we know why, because PSA is considered as the tumor marker beta. Best tumor marker is PSA, but in the recent FMG exam, PSA was not an option. So when prostate specific antigen is not an option for prostate cancer, we have discussed in biochem and surgery both. What is the second best tumor marker beta? Jan 2025 question. If PSA is not an option, second best tumor marker has to be. Anybody, let me know in the chat box. If they ask you beta investigation of choice, हमें पता investigation of choice has to be beta a trust guided biopsy beta, that is a transrectal ultrasound guided biopsy. याद रखना बेटा, a trust guided biopsy or a transrectal ultrasound guided biopsy which is there is the investigation of choice in a patient of prostate cancer बच्चे. And once you confirm the diagnosis beta with the help of a trust guided biopsy, then you will move on to the treatment beta. Yes, तो याद रखना the second best tumor marker after serum prostate specific antigen is acid phosphatase beta. Acid phosphatase has to be the second best tumor marker. Important is if they ask you about the treatment, तो याद रखना treatment depends basically whether the patient comes to us in the early or advanced stages beta. When the patient comes to us in the early stages, matlab when the cancer is only within the prostate gland, then I can go for a radical prostatectomy, that is a surgery. Radical prostatectomy mein I have to remove the prostate along with the obturator lymph nodes beta. But whenever the cancer spreads outside the prostate gland, whenever the patient comes to me in advanced stages of prostate cancer beta, in that condition definitely what I have to go for, in those conditions I should go for definitely beta either a brachytherapy. Let me know, June 2022 question, that brachytherapy or radiotherapy of prostate cancer is done with the help of which radioactive iodine beta. Which radioactive iodine is used for the treatment beta? Which radioactive iodine is used for the treatment or brachytherapy of prostate cancer? Let me know in the chat box. If brachytherapy you don't want to go for, you can go for a hormonal therapy. Why? Because we know beta that prostate cancer is also a hormone dependent or hormone driven cancer like breast, and as it is a hormone dependent or hormone driven cancer like breast, it can be treated by hormonal therapy beta. That is what is important to remember. Clear about? याद रखना, these are the points that you have to remember beta. For hormonal therapy, you can give definitely anti-androgens to the patient beta. Anti-androgens can be given, or you can give GnRH antagonist as well. You can give GnRH antagonist beta, or you can give GnRH agonist. How GnRH agonist? Please remember, when GnRH agonists are given in a pulsatile manner, then they will cause stimulation. But when GnRH agonists are given in a continuous manner beta, they will cause suppression. Okay, so that's the reason we can give GnRH agonist beta, but in a continuous manner bache, for hormonal therapy of prostate cancer. Very good. Yes, it is iodine 125 basically bache, which is going to be the radioactive form of iodine that is generally used for brachytherapy in prostate cancer. That was a PYQ and FMG exam. Very good. For thyroid related problems, it is iodine 131 that we use for treatment. But for the brachytherapy in prostate cancer, it is iodine 125 beta, which we use for treatment. Yeah, that is all about your urology. And last part is hernia beta. Now, when I talk about hernia, bache, we know hernia is what literally, the literal definition is protrusion of a viscus or a part of a viscus through the wall which contains it. Iska matlab, whenever any internal organ will try to come outside its wall beta, that is a herniation beta. For example, if intestine or the bowel tries to come out basically from the anterior abdominal wall, that will be called as a herniation. Important is we know any hernia in the anterior abdominal wall is called as the abdominal wall hernia or a ventral hernia, and any hernia in the inguinal or the inner thigh region is called as groin hernia beta. If I talk about basically the abdominal wall hernias, they can be first any herniation from the linea alba or from the midline of the abdomen beta. Any hernia from this linea alba or the midline of the abdomen is an epigastric hernia beta. Any hernia basically from the umbilicus is called as the umbilical hernia. Any hernia from the umbilicus is known as the umbilical hernia. Any herniation from 2 to 3 centimeters range around the umbilicus is known as paraumbilical hernia. Any hernia within the 2 to 3 centimeter range of the umbilicus is known as the paraumbilical hernia. Any hernia that arises from the lateral border of rectus abdominis is a Spigelian hernia. Any hernia from lateral border of rectus abdominis muscle is a Spigelian hernia. Any hernia from a previous incision or scar. Any hernia from a previous incision or scar is an incisional hernia beta. Clear? So these are all your abdominal wall hernias basically beta, or all your ventral hernias definitely. इसके अलावा we know beta that we can also have herniation from the inguinal or the inner thigh region. Any herniation from the inguinal region beta will be called as an inguinal hernia, and any herniation from the inner thigh region will be called as a femoral hernia beta. Clear about? Now, if I talk about basically, bache, if they ask you out of all these hernias that we have discussed, which is the most common type of hernia? So we know most common type of hernias will be groin hernias, beta. In groin, more common type of hernia will be inguinal hernias. Now we know, beta, that inguinal hernias are of two types. Kaise? For example, bache, let's say this is your deep inguinal ring, beta. Okay, this is your inguinal canal, and this is your superficial inguinal ring. Above and behind this inguinal canal, we have a Hasselbalch triangle, beta. Above and behind this inguinal canal, we have this Hasselbalch triangle. Let me know in the chat box, beta, that deep inguinal ring is opening in which layer of abdominal wall, and superficial inguinal ring is opening in which layer of the abdominal wall. Let me know these two things, beta, which are commonly asked from anatomy and surgery. Deep inguinal ring is the opening in which abdominal wall layer, and superficial inguinal ring is the opening in which abdominal wall layer. Let me know in the chat box. That is important. We know, which is that whenever any herniation occurs, okay, whenever any herniation or whenever any hernial sac enters from the deep inguinal ring, it is always an indirect inguinal hernia. Whenever any hernial sac enters from the deep inguinal ring, it is always an indirect inguinal hernia. And whenever any herniation happens from the Hasselbalch triangle, that is always a direct inguinal hernia. Whenever there is any herniation happening from the Hasselbalch triangle, it is always a direct inguinal hernia. To differentiate, beta, here we have a set of vessels called as the inferior epigastric vessels. So here you are going to have the inferior epigastric vessel. Yaad rakhna, any hernia which is lateral to the inferior epigastric vessel will be called as the indirect inguinal hernia, and any hernia that is medial to the inferior epigastric vessel will be called as the direct inguinal hernia, beta. That is important to be remembered. Shabash. Yep. Okay, great. So please remember, beta, yaad rakhna, whenever I talk about deep inguinal ring, we know deep inguinal ring is definitely opening in the fascia transversalis. Deep inguinal ring is opening in fascia transversalis, whereas superficial inguinal ring is opening in external oblique aponeurosis, beta. Superficial inguinal ring is opening in external oblique aponeurosis. Very good. That is what is important to remember. Yaad rakhna. Okay, we know sometimes the inguinal hernia, beta, can even come down into the scrotal sac as well. There can be a scrotal extension of the inguinal hernia at times as well, beta. That is important. Clear? So hernia lateral to inferior epigastric vessel is indirect, medial to inferior epigastric vessel is direct. So if they ask you, beta, which is the most common type of hernia overall, we know that the most common type of hernia overall is the indirect inguinal hernia, beta. The most common type of hernia overall is always the indirect inguinal hernia. That is what is important. If they ask you, which is the most common type of which is the most common type of hernia in elderly patient? The most common type of hernia in elderly patient is the direct inguinal hernia. So direct inguinal hernia, which is there, beta, it is considered as the most common type of hernia. That most common type of hernia in elderly patient. Most common type of hernia in elderly patient is direct inguinal hernia. Most common type of herniation in females, if they ask you, most common type of hernia in females, let me know in the chat box. Most common type of hernia in females, let me know in the chat box. बोलो. Most common type of hernia in females, if they ask you. Very good. The most common type of hernia in females, if they ask you, beta, answer is always the indirect inguinal hernia, bache. The most common type of hernia in females, if they ask you, answer is always an indirect inguinal hernia, beta. That is what is important to be remembered. Yaad rakhna ye baat. We know, beta, that femoral hernia is 4 times more common in females. If you compare both the sexes, then femoral hernia is more common in females, but it is not the most common. Most common hernia in females is also an indirect inguinal hernia itself. Clear? Now, if I talk about the major differences, beta, we know that the inguinal hernias which are there, they are indirect and direct. The indirect inguinal hernia which is there, beta, it is more commonly seen in younger patients, whereas direct inguinal hernia is seen in elderly patient. Why? Because direct inguinal hernia mein the herniation directly comes out from the abdominal wall, beta. Why? Because the abdominal wall is weak, and we know abdominal wall will be weaker in elderly patients, beta. We know any herniation that passes, or any hernial sac that passes via the deep inguinal ring, beta, is called as the indirect inguinal hernia. Any sac that passes via the deep inguinal ring is called as deep inguinal, any hernial sac that comes out via the deep inguinal ring is an indirect inguinal hernia, and any hernial sac that comes out via the Hasselbalch triangle. Any hernial sac that comes out via the Hasselbalch triangle बच्चे is a direct inguinal hernia. Hopefully that's clear. If they ask you beta direction of hernia, हमें पता है that the indirect inguinal hernia which is there, that is going to be बच्चे downwards, inwards and forwards. बराबर. तो याद रखना definitely that the indirect inguinal hernia which is there, it is coming downwards, it is coming inwards, that is medial, and it is going downwards beta. But the direct inguinal hernia which is there, it is only and only coming forwards or outwards beta. Direct inguinal hernia only comes forwards. Relation with inferior epigastric vessel, we all know indirect inguinal hernia will be lateral to the inferior epigastric vessel and direct inguinal hernia will be medial to the inferior epigastric vessels beta. That is important. Scrotal extension की बात करेंगे तो we know बच्चे that scrotal extension is slightly more common in indirect inguinal cases but less common in direct inguinal hernia. So scrotal extension is more common in the indirect inguinal hernia, less common in the direct inguinal hernia beta. Let's talk about the inguinal hernia surgeries. I hope all of you are quite aware beta. There are three types of surgeries for hernia. First condition is when the defect is very small beta. When the defect is very small, then you just push back the hernial sac beta. Okay, and you don't close the defect. Whenever I just push back the hernial sac and I do not close the defect बच्चे, this type of surgery is known as herniotomy. बराबर, this type of surgery is known as herniotomy. Second, when the defect is small to moderate in size, whenever the defect is small to moderate in size, I push back the hernial sac beta, and after pushing back the hernial sac, I am now going to close the defect बच्चे by pulling the layers together. Now when I pull the layers together beta, I am going to close the defect with the help of sutures. So I will pull both the layers together to close the defect, and then I am going to suture these layers together beta. So whenever I close a defect of hernia beta with the help of sutures, that is known as herniorrhaphy. Whenever I close the defect with the help of sutures, that is known as herniorrhaphy. And third, whenever the defect is very big in size, then I cannot go for a rhaphy beta. Why? Because when the defect is very big in size beta, I cannot pull those layers together. Even if I try to pull the layers together and suture them, the sutures are going to break beta due to excessive tension in them. Therefore, in these conditions beta, I better place a mesh over the hernial defect beta and I close the defect with the help of mesh. Whenever I close the defect with the help of a mesh beta, that surgery is known as an hernioplasty. That surgery is known as an hernioplasty. Hopefully clear to all of you now. So that is what is important. Clear? Now if I talk about the herniorrhaphies that we do for the inguinal hernia. The herniorrhaphy that we do for the inguinal hernia beta, it is nothing else but called as a three-layered repair called as Bassini's repair. It is a three-layered repair called as Bassini's repair, or second is a Shouldice repair, or the third is a modified Shouldice repair. So ये जो भी है बेटा, Bassini's repair, Shouldice repair, modified Shouldice repair, all of them are definitely बच्चे nothing else but the herniorrhaphies that we definitely do बच्चे for the closure of a inguinal hernia beta. Clear about? But herniorrhaphies, as I've told you beta, as you are closing the layers with sutures, it is only possible for small to medium sized defects, and second, here the chance of recurrence will be there if there is too much tension in the sutures beta. So the best surgery is hernioplasty beta. Now when I talk about hernioplasty, there it can be of two types. Either it is a open hernioplasty beta or open surgery, or a laparoscopic surgery. The open hernioplasty that we do बच्चे is classically called as the Lichtenstein's repair. The open hernioplasty that we do बच्चे, it is classically known as the Lichtenstein's repair. So Lichtenstein's mesh hernioplasty or the Lichtenstein's tension-free repair is the open hernia surgery beta that we do for inguinal hernia nowadays. Well, let me know beta which is the most common nerve injured in open inguinal hernia surgery. So open inguinal hernia surgery like a Lichtenstein's mesh hernioplasty, which is the most common nerve injured, let me know in the chat box. Next is a laparoscopic inguinal hernia surgery. Laparoscopic inguinal hernia surgery mein beta definitely there can be two surgeries beta. One is a tap repair. Tap repair is nothing else but a transabdominal preperitoneal repair, and second is a TEP repair, that is a total extraperitoneal repair. Now tap repair mein what happens? Tap repair mein beta we go inside the peritoneal cavity and we definitely repair the defect from inside. Matlab we place a mesh from inside beta. That is a tap repair. TEP repair mein definitely we are going to repair the defect but from outside. We are not going to breach the peritoneum beta. That is total extraperitoneal repair. Clear? Very good. So yaad rakhna beta, the most common nerve that is injured, in an open inguinal hernia surgery like a Lichtenstein's repair is the ilioinguinal nerve beta. That is a very common question of your exam. Whereas let me know now the most common nerve that is injured bache for a laparoscopic inguinal hernia surgery. Let me know the most common nerve that is injured bache during a laparoscopic inguinal hernia surgery. That is important again. We know laparoscopic inguinal hernia में laparoscopic inguinal hernia surgery में whenever a nerve is injured, patient will have loss of sensations from the upper lateral part of thigh beta, okay, or a shooting pain in the leg, loss of sensation in the upper lateral part of thigh or a shooting sensation in the leg beta, that is going to be seen. The most common nerve injured in a laparoscopic inguinal hernia surgery, and that answer is going to be that loss of sensations in the upper, okay, the loss of sensations definitely in the upper lateral part of thigh is basically called as meralgia parasitica. And very good, meralgia parasitica happens whenever there is damage to the lateral cutaneous nerve of thigh beta. So whenever there is damage to the lateral cutaneous nerve of thigh, that causes meralgia parasitica, and that is the most common nerve injured beta in a case of laparoscopic inguinal hernia surgery. That is very important. Recent NEET PG and multiple times asked in the examination beta. Congenital hernia की अगर मैं बात करूँ, please remember congenital hernia में बेटा the surgery is nothing else but herniatomy. So congenital hernia and congenital hydrocele, both of them are treated by herniatomy beta. What do I mean by herniatomy? Here you will just push back the hernia beta, we will not close the defect. Why? Reason beta, the bacha is going to grow. Congenital hernia seen in children, na, the child will grow, and as the child grows beta, the defect is automatically going to close. Bache, the defect is automatically going to close. Iसीलिए we don't need to close the defect in congenital hernia. But congenital hernia के लिए herniatomy is also done after 3 years of age. Why? Reason beta, majority of the congenital hernias are self-resolving. अपने आप ठीक हो जाते हैं up to 3 years. But if the congenital hernia is not going to resolve beta by 3 years of age, then you after 3 years you go for a herniatomy surgery. Abdominal wall hernias की अगर मैं बात करूँ बच्चे, तो याद रखना abdominal wall hernias में there are two options. Either I can go for a herniorrhaphy surgery, that is called as a Mayo's repair beta. Okay, so whenever I close the abdominal wall defect around 1 to 2 centimeter का defect beta with the help of a herniorrhaphy surgery, that is called as a Mayo's repair बच्चे. But whenever the defect is more than 2 centimeters or whenever the defect is moderate to large in size, I have to go for a hernioplasty, and that hernioplasty surgery can be IPOM beta. IPOM is nothing else but intraperitoneal placement of mesh. Intraperitoneal placement of mesh beta is a hernioplasty surgery that we do for abdominal wall hernias. We know femoral hernia surgeries can be McAvidy's repair, Lothison's repair, or Lockwood's repair. So McAvidy's, Lothison's, and Lockwood's, these are the types of repair beta of the surgeries that we do for femoral hernia. That was all about your hernia. Okay. So that is what is important. Chalo, that was all about your surgery revision beta. Take your lunch break, 45-50 minutes, and then after that we'll start with your surgery test and discussion. Okay. Chalo. Don't get afraid of the test and discussion beta. It is fine. Definitely there will be some questions which will be completely out of the box, that you have to keep in mind. Clear about? Chalo.